Hello, can you guys hear me? Hello.
Yes.
Okay, that's perfect. Okay, so as you all guys knows that today is going to be our bootcamp session, and the most awaited event. I would say most of the students were asking for me that when is going to be our bootcamp session. As we mentioned already in the beginning, that right after completion of every system, we'll be having a bootcamp session. Okay, so I want you guys to be here for at least 3 to 4 hours, right? So after every 1 hour, we are gonna have like 5 to 10 minutes of break, and we'll be discussing the entire cardiovascular as you guys did it with Dr. Moa. So I'm expecting a lot from you guys. Yes, the section is being recorded. You don't have to be worried about that. So the best way to do this cardiovascular boot camp is to kindly take your first aid and open it in front of you, right? So we'll be following the pattern of first aid. I'll be marking the high yield as well as I'll also be asking some MCQs from you, like in the middle, and you guys have to answer me that. Okay, and then we'll be sharing our last. Okay, after this cardiovascular session, we're going to have an assessment session. Along with that, we're going to have one task as well that's left for pharmacology, right? So today I'll be discussing till pharmacology, and the pharmacology boot camp is going to be continued tomorrow. Okay, and after that, okay, sir, could you please make it? Okay, you don't have to be worried about that. Pharma is going to come in the end. Tomorrow I'll be having a detailed, I'll just resume this cardiovascular boot camp. I'll be discussing till like the pathology section, right? So all of you guys have to keep open your first aid in front of you, because like it's going to be an intensive session, and I'll be starting within 3 minutes. So you guys have 3 minutes to take your first aid and open it in front of you. Okay. Hello, is that clear?
Yes.
Okay,
Yes.
perfect. So
Yes, sir.
283 page. Those who do not know the page number, they should just open the 283 page. We'll be starting from embryology. Okay, and in the middle I'll be making some MCQs for you. Like I'll be verbally asking you some MCQs which are going to be tested on your U world as well as your assessments too, right? After this, you guys are going to have assessment, and in the assessment we'll also announce the top scorer, right? The first 5 top scorer, and in the future we are going to give them a lot of perks. Okay, so you guys have to be like participating actively in this bootcamp session. Okay, so remember, in this bootcamp session, you guys are going to participate. I'll be taking your names, and whatever I'm asking from you, you guys must be telling me that. Okay, so you have only 2 minutes left. Those who do not have their first aid along with pencil, so kindly take your pencil and first aid and just open it in front of you. We'll be starting from cardiovascular embryology. Okay. Yes, after the session, I'll after 1 or 2 hours after the session, I'll be just turning on your assessment. Okay. Do you guys have any questions regarding the bootcamp session? We have 1 minute left. Okay. So after the session, we're gonna have a bootcamp session. Sorry, the assessment session. Okay. Okay. So can you guys just see my screen?
Sure.
Okay, that's perfect. Okay. So I want every one of you to be like, as active as me. Okay. Okay. So let's start our embryology first, right? Okay. So what's important in embryology? All of you guys should be having their first aid book in front of them. Okay. So you should know the first thing is that when do heart develop? That's fourth week of development, right? And how and what kind of MCQs are you going to be asked, like on expect a 4 month of development? Like they're going to give you like let's suppose an ultrasound picture, and they're going to mention that it's the 4 week of development and we started seeing some movement. What do you think, which organ is developing here? So that's going to be your heart. Keep that in mind. Okay, so heart beats spontaneously at fourth week of development, and this is the way they're going to ask you, right? Okay, besides that, remember, heart is first of all, like you can just simply imagine that it is made at right side of your body, right? Right side. But Due to the cilia movement, it's pushed towards the left side, which is the normal anatomy of your heart, right? So cilia movement is really important, or ciliary movement is important in normal configuration of your heart, like that is the heart being at the left side of your body. Ciliary movement is very important for that. Not only for your heart, but cilia is important in other things as well. You guys know that sperm mortality, right? It's important for your respiratory system as well. For
Hello.
We're not you, Dr. Ahmed.
I'm not able to hear you, Dr. Ayman.
Hi, hello.
Hi. Yeah, I think there's a problem in the with Dr. Ahmed's account because we can't hear anything.
Yeah, seems you.
Mhm.
Sorry, can I ask? The first aid, I have my own copy of my own, but is there any available online on the Discord server? Because I can't get onto the Discord server.
You can find one on a Telegram. 2025 USMLE first aid.
I think 2025 and 2024 both are same.
No. There is added information in 2025. I was referring to 2024. So I found some added information in 2025. It's better to go with latest version.
All right.
Someone posted 2025 in the group so you could get it from there.
Oh, did you say you posted it?
No, someone else posted it in the group. So if you check the WhatsApp group, it's posted there now.
Oh, okay, good.
Yeah.
Thank you, Fatima.
Why can't I find it? Next generation. First it.
I'm sorry, in which WhatsApp group? The admin or the...
The
Next
regular
generation.
NextGen.
Yeah, found it. Thank you.
Copy this.
Can someone resend it in the group? I can't find it here.
Refresh.
Hello? Hello, am I audible now? Hello?
Yes.
Yes.
Okay. So I just almost just okay. Where? So let's start from the beginning. Okay. So we were discussing about embryology, right? So the first thing which we discussed was Cardiovascular syndrome. So what is Cardiovascular syndrome? As we discussed that normally your heart like initially was at your right side, right? But then a ciliary movement occurs and this ciliary movement led to the normal orientation of your heart. That is the heart was brought by this ciliary movement towards left side of your chest. Is that clear? Hello?
Yes.
Hello? Okay, perfect.
Yes.
Yeah.
Kindly respond, okay? So in this way, I would know that you guys are getting me. So as we discussed, that ciliary movement is not only responsible for this kind of function that is bringing your heart to its normal orientation from right to left, but ciliary movement is also important in your like respiratory system as well, in your sperm motility as well, right? That's the flagella, right? But the main important component which lead to the movement of cilia is going to be your dynein protein, right? Is that clear? So whenever we have defect of dynein protein, the ciliary movement won't occur. If the ciliary movement do not occur, what happens? You cannot push your heart to the left side of your chest. And if we cannot push the heart to the left side of the chest, what's that condition called?
Cardiac syndrome.
Dextrocardia, right? Dextrocardia. And the problem is due to Cardiovascular syndrome. But not only this problem, we won't be having a sperm motility as well because flagella itself needs dynein protein in order to beat properly, in order to get the egg fertilized. So there would be infertility as well. And besides that, as we discussed, that ciliary movement is also important in your respiratory system in order to push all of the particulate dust back into your pharynx. Either you can just spit it out, either you can swallow it. So if we do not have ciliary movement there, what would happen as a result of that? You'll be having pathogens, you'll be having particulate substances building up, like, within your lungs, and as a result of that, it would lead to stasis. And stasis leads to infection. You already know that, right? And if it leads to infection, recurrent infection can cause a lot of problems. For example, bronchiectasis. We'll be discussing what is bronchiectasis, but you should just keep in mind, whenever we have recurrent infection, so it's going to, like, damage your bronchioles, with like a chronic pace. And as a result of that, it would lead to permanent dilatation of your bronchioles. And as a result of that, it would lead to bronchiectasis, which is like necrotizing, infections again and again up in your lungs, which is leading to permanent dilatation. Is that clear? Hello?
Yes.
So,
Yes.
like, they can simply ask you, we have an individual, we did some imaging, and his heart was present at the right side of his chest. This is one of your MCQ which they are going to. What's the main syndrome leading to this problem? Yes.
Cardiovascular syndrome.
Cardiovascular syndrome. And what is this condition called? That's so correct.
Dextrocardia.
Okay, if this individual was supposed to die from, some, let's suppose, pulmonary pathology, what are you expecting? Which pathologies can be there?
Cystic
Bronchiectasis.
fibrosis.
Cystic fibrosis. Okay.
Primary ciliary dyskinesia.
Okay. Primary ciliary dyskinesia. That is the ciliary won't, or the ciliary process won't move properly. It would lead to infection. There can be pneumonia. There can be bronchiectasis. There can be a lot of problems, right? So you should just keep on things in mind. You should just keep on this association. For example, you have an individual who is right, his chest X-ray showing that the heart is present at the right side. Will this individual be capable of, fertilizing an egg, or producing an offspring? Yes or no?
No.
No. Why? Because the flagella itself need dynein protein to get, to get into the uterus and into your egg. Just keep those things in mind. So these kinds of questions are going to be asked from you guys. Okay. Shall I just move to the next topic?
Yes.
Yes.
Perfect. Okay. So the next topic which we are going to discuss is air septation, right? So I'll be just discussing the event like quite quickly, because it's going to be like, I'm more going to be focused on the high yield, but I need you guys to know the details as well. For example, this is your atria. The first, okay, these are your, yes.
Endocardial cushion.
Perfect. Endocardial cushions. The first septum is going to be formed from the superior pole. It will just come down. You just stop here. This septum is known as septum
Primum.
Primum.
What's this?
Ostium.
Foramen primum.
Ostium.
Ostium or foramen primum. Perfect. After that, it would just join, and this part is going to undergo apoptosis. It's going to form a foramen. What
Ostium secundum.
Ostium secundum. Perfect. And then the next septum.
Septum
secundum. It's only going to be coming from the superior pole or both the poles?
Superior.
Both superior and inferior pole. Keep that in mind.
Both.
Yeah. So what would happen as a result of that? We'll be having a one-way valve, that is foramen ovale, right? Oh, that's perfect. Okay. Normally this have to be closed, but if it do not close, it can lead to a condition PFO, right? Hello?
Yes.
So we'll be discussing PFO. There is a thing which is known as paradoxical emboli. Who is going to be telling you the concept of that?
When the emboli enters to the systemic because of this PFO.
Perfect. So whenever the left-sided, whenever the right-sided emboli enters into the left-sided emboli, normally it cannot occur, right? If an individual is having DVT, he do not have any atrial septal defect, he do not have any patent foramen ovale, then what is the fate of the emboli, where it would stuck, where it would go?
In the lungs.
In the lungs,
Yes.
it would just cause pulmonary embolism. But if we have ASG, then there is increased chances of getting this DVT or thrombus into the left side circulation. That is whenever the right side increases during Valsalva maneuver, right? Which phase of Valsalva maneuver?
Release phase.
Release phase. Perfect. During release phase, the right-sided preload increases. We already have discussed all of these things. So these kinds of questions are going to be tested from you guys. Okay, so once this on right-sided emboli get into left-sided, it can either enter into CNS, giving you which stroke? What's the name of that? Something cryptogenic stroke, right?
Ischemic.
Cryptogenic.
Cryptogenic stroke. It can enter into your kidneys. It can enter into your like ischemic, like bowel circulation. It can give you a lot of problems here, right? That is ischemic bowel syndrome and everything. So this was all about the ASD, right? Okay, what do we perform in order to diagnose, let's suppose, ASD pattern for a manual, something related with normal saline?
Bubble study.
Bubble study.
Hypersaline infusion.
Bubble studies, that is agitated normal saline infusion. On imaging, if you are seeing bubbles within the left side, it confirms that we have some
PFO.
defect,
P or
right?
PFO.
Or,
ASD.
for example, if you have an individual, he's having atrial fibrillation, that is ectopic foci near the opening of your pulmonary veins, you want to radio ablate that. So what's going to be the what's going to be the pathway of the catheter? How are we going to approach that left-sided?
From right atrium via this septum and
Septum.
Okay,
atrial septum,
Septum.
and it will go to the left atrium.
cutting the septum, right? Cutting the
Yes.
septum, going into left
Intra-
atrium and burning the spots. Okay, I'm just using a layman language here so that things are clear, right? So you're going to insert the catheter into right atrium, just cut the septum, get into left atrium, burn those ectopic spots, and atrial fibrillation is going to be corrected. Is that clear? These were all of the MCQs which you guys must know, all of the entire things. I'll discuss each and every MCQ of your world as well here, okay? Is
Okay.
it clear? Okay. So we discussed the Valsalva release phase, we discussed pattern foramen ovale. Okay, so for example, if you have an individual having ASD, what heart sound is associated with ASD? Very
Wide
important.
splitting of S2.
Wide
Wide
splitting.
splitting of X2.
Wide, fixed split or only wide split?
Fixed.
Wide
Fixed.
split.
Wide.
Thing of S2.
Wide fixed.
Split of S2. Perfect.
Because
So this was all
installation
about your atrial septation. So the next topic which we are going to discuss is your ventricles or ventricular septation, right? So normally we know that ventricles also have a septum, right? And these endocardial cushion cells, if you guys do not remember, so they would help in 4 things. Remember that, okay? That is information of ASD. That is atrial septum, not D, okay, not defect. Atrial septum, it would have information of your ventricular septum, but that is the membranous portion. It would have information of your AV valve for AV valve, that is your mitral valve and tricuspid valve. And the 4th thing is going to help make your
Semilunar. Semilunar.
pulmonary septum, right? So these are the 4 things which your endocardial cushion helps in developing. Okay, so the membranous portion is of your interventricular. So you have a muscular portion and the membranous portion. So the membranous portion of interventricular, again, endocardial cushion cells helps information on that. And it's the what's the most common site of defect if you are suspecting any ventricular septal defect? So it would be more probably in the
Membranous part.
muscular or membranous.
Membranous.
Membranous septum because it is thin.
Or perfect. Or kindly raise your hands before participating. Okay, membranous portion. If you have VSG, so let's discuss all of the keyword MCQs, the NBME's concept here, so everything is clear. Okay, so the first concept which we are going to discuss here is we are having an VSG. What is going to be the murmur associated with VSG? Please raise your hand before answering the question. Okay, Dr. Humaira.
Hollow systolic murmur.
Okay, it's going to be hollow
Systolic.
systolic. Where are we going to auscultate it? Very
Tricuspid.
important.
Lower sternal.
Tricuspid.
Just tell me the area. Don't tell me.
LLSB. Left lower sternal border.
Left lower sternal border.
Left lower
Mm.
sternal border. So now there are 2 things. Let's discuss about oxygen concentration. Let's discuss about the pressure. If you have an VSG, what would be oxygen concentration in right ventricle? What would be oxygen concentration in right atrium? Your left atrium and left ventricle. First of all, the oxygen concentration. Just starting from the left ventricle. In
Left
terms of
ventricle.
increase, decrease, or constant. In terms of increase, decrease, or constant. The left ventricle, what's going
It
to be the
will be
oxygen?
constant.
Left
Okay, it's going
ventricle will be constant and right
Constant.
ventricle will be
LV
increased.
constant. RV increase.
what happens in right ventricle? The oxygen
Increase.
concentration.
Increase.
What about right atrium?
It should be constant, normal.
What about the left atrium?
It should be constant.
It should be constant. Perfect. Let's discuss some pressure changes. What would happen to the pressure changes within the right ventricle?
It should increase.
Yes, what do you guys think?
It will increase in the right ventricle.
What happens in the pressure within the right atrium?
It should be normal.
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 Okay, what about the pressure in the left atrium?
It should increase.
Increase. Yeah.
Yes, what do you guys think?
It will increase because
Decrease.
return will increase. Blood
It
return
will
will
increase because more blood is entering into your lungs. It means more blood have to come back into your heart as well. What about the pressure in the left ventricle?
Increase.
Again, increase.
Again, it would increase further. Let's discuss last concept which MBME loves to test, right? Regarding this condition. So, for example, if we have this defect, and if the defect size is small and the defect size is large, what would happen to the intensity of murmur when it is small?
when it is
Increase.
Intensity increase.
What will happen to intensity when the defect is
Reduce.
large?
Reduce. Low.
Decrease. Yes. Mhm.
Perfect. So that's everything which you should know regarding your ventricular septal defect. Is that clear?
Yes.
Hello? Okay. So these things, that is outflow tract formation, we are going to discuss this in pathology section. So for now, you guys can just skip it, as well as the valve development. Okay, for the heart embryology, 3 things you guys should be just keeping in mind, right? We won't be discussing the entire one. That is cardinal veins, right? So you have right common cardinal veins and right anterior cardinal veins. That's going to give rise to your superior vena cava. Cardinal veins into is going to give rise into vena cava.
Superior vena
Keep that
cava,
in mind,
yeah.
right? So keep that in mind. Very important. You have a U-word MCQ on that. Except that you should just keep in mind that okay, what else? Endocardial cushion. We already discussed. You want to give rise to your interatrial septum, interventricular septum, AV valve formation, aortopulmonary septum, right? Truncus arteriosus, ascending and
Ascending aorta.
Ascending aorta
And pulmonary artery.
pulmonary. Perfect. So that's higher things which you guys have to keep in mind. And let's move to our next topic, that is fetal circulation. So what's important in fetal circulation? We know that blood is going to be brought into the fetus via umbilical artery or vein.
Why?
Vein.
Vein.
Okay, veins bring blood towards heart, right? Then what happens? It's going to pass through 3 shunts. First of all, it's going to skip the liver via a shunt. What's the name of that shunt?
Ductus venosus.
Ductus venosus, and it's going to enter into inferior vena cava, right?
Yes.
And now, like in the inferior vena cava, there is going to be highest, yes,
Oxygen.
concentration of
Oxygenation.
highest oxygen concentration. One of your UWorld MCQ, if you guys remember, right? Inferior vena cava.
Yes.
Then it's going to enter into your heart. In the heart, it's going to enter into your right atrium. It's going to bypass the lungs.
PFO.
Into left atrium. For example, if some of the blood, let's suppose, enter the ventricle, then we have another shunt as well. That is from pulmonary artery into
Ductus arteriosus.
that is ductus artery. Is that clear? You should just keep these 3 things in mind. Okay, the next thing which we are going to discuss is that, okay, at birth, what's the pressure changes at at birth and before birth, right? So at birth, can you just tell me what's at birth, the right-sided circulation is a high pressure system or the left-sided?
Left.
Left-sided.
Left-sided.
Right-sided.
Initially right-sided with when the child started to breathe, then decreases the pulmonary pressure
Okay.
and gradually increase the
as the-
left-sided pressure.
Okay, so let's discuss before birth. So before birth, as we know that lungs are collapsed, right? Lungs are collapsed because we know the nature of lungs, right? You should just keep this thing in mind. You know, you are going to be seeing this concept again and again. Whenever we have systemic, in the systemic circulation, whenever we have hypoxia, we are going to have vasodilation or vasoconstriction.
Vasoconstriction.
No, for the
In the lungs,
dilation.
in the
In the
lungs,
lungs will be
there's two
constriction.
in the lungs and
Please,
general system.
whatever.
In the lungs, due to hypoxia, will be vasoconstriction.
Okay. So in the systemic circulation, whenever we are having hypoxia, it's going to lead to vasodilation, right? Because
in order to increase the flow and
okay, really sorry. So whenever we have hypoxia, so we are going to have a lot of adenosine there, vasodilation, and it's going to lead to vasodilation of your arteries in order for that part, the hypoxic part, to get perfused. That makes sense, right?
Yes.
Okay. Well, in case of lungs, whenever we are having hypoxia, it's going to lead to
Vasoconstriction.
vasoconstriction. That
Yeah.
also makes sense. Like for example, if this is our lung, let's suppose these are our different alveoli. And for example, if we have hypoxia here, due to some obstruction, this blood vessel is going to be constricted. And the reason for that, it's also really important. It makes sense because due to vasoconstriction, it would divert all of the blood to well perfused alveoli in order to get maximum amount of oxygen. Does that make sense?
Yes.
Okay.
yeah,
So in the fetus, basically we do not have oxygen. We have hypoxia. So due to hypoxia, what would happen? We have lungs are collapsed. As the lungs are collapsed, the vessels are also collapsed. And as a result of that, what happens? The pulmonary artery pressure is really high. The afterload is really high. And if the afterload is really high, what happens as a result of that? The right-sided pressure are greater as compared to the left-sided pressure. That's why the blood is going to shunt through foramen ovale. Does it make sense?
Yes.
Now, if the is born, if you have proper amount of oxygen within the lungs, your vessels are going to dilate. As your vessel goes dilate, what happens to the afterload? Afterload decreases. Afterload decreases. Now the left side circulation is more as compared to the right side circulation. And if you have more left side circulation, it would just, you have septum primum and septum secundum. It would just push the flexible septum primum against the stiff septum secundum, and after some time it would lead to fibrosis and closure of your foramen ovale, right? And what else? For example, this is your aorta, this is your pulmonary artery. Now the oxygenated blood is flowing in the retrograde direction because the left side circulation is more as compared to the right side in the ductus arteriosus, right? So how does the ductus arteriosus get closed? Keep that in mind, really important, really high yield. Okay, there are two things which lead to closure of your ductus arteriosus. The first thing is you have to lower your prostaglandins, right?
Yes.
Yes.
Why? Because prostaglandin dilates or keep open your ductus arteriosus. For that, we have to give NSAIDs. And which NSAIDs, by the way? They're really important.
Endomethacin,
Endomethacin.
acetaminophen, ibuprofen.
Okay, endomethacin, that's the important one. You guys have to keep that in mind. Okay, another thing, we need retrograde. Okay, that isn't mentioned in your first set, so you should just write it down. Really important. You need a retrograde flow of oxygenated blood in ductus arteriosus. That's also going to close your ductus arteriosus. Like normally the blood is going to flow from the pulmonary artery into the aorta. This is the normal direction of your blood flow. Am I right?
Yes.
And that blood is going to be deoxygenated. We know that normally in the fetus, right?
Yes.
Yes.
So whenever we have oxygenated blood flow in retrograde direction, it's going to lead to closure of your ductus arteriosus. And the concept here is quite simple. We have some K plus oxygen dependent potassium channels which are going to get activated. Yes, and once they get activated, it's going to lead to constriction of ductus arteriosus, and in this way, ductus arteriosus is going to be closed. So, if we know that retrograde flow of oxygen, oxygenated blood in ductus arteriosus also leads to closure. So, can I say that if I want to close the ductus arteriosus of a baby, he appeared, right? what can I do? I can give him answers, right? Can I give him 100% oxygen? Would that help in closure of the ductus arteriosus?
If there is no other pathology, we can give
No.
oxygen.
No, I think no.
No, it won't close it.
What
No,
do you
if
guys-
there is no pathology, then there is no harm. We keep the hypoxic patient if there is another pathology other than PDA.
Okay. So basically, increased oxygen along with NSAIDs is going to help closure of ductus arteriosus. Keep that in mind. Okay. Is that clear? Because we discussed that retrograde flow of oxygenated blood in ductus arteriosus is also somehow going to lead to closure of ductus arteriosus. We have two factors. Is that clear?
Yes.
Yeah.
Yes.
Oh, perfect. So that was all about embryology. Hope so you guys enjoyed. Let's move to our anatomy. Are you guys enjoying the bootcamp session?
Yes.
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 Oh,
One
that's
more
perfect.
thing, Dr. Ahmed, due to closure of the placental circulation, which is a low circulation, it also increases the systemic pressure.
No.
Oh, yeah. Yes,
Placental
that's okay.
suppress.
You were discussing about this. Okay. Okay, so you're talking about the systemic circulation pressure, right? So what happens after the birth? What happens to the pressure in left side circulation? That's going to increase. Okay, like it's going to be high resistance system now, right? Why?
Because
Hello?
low resistant venous circulation of the placenta is closed.
Placenta is also removed. If the placenta is removed, like we know it's an example of parallel circuits we will be discussing. If you're removing any part or any resistance in case of parallel circuit, the overall resistance increases, right? So as we are removing the placenta, so the resistance there in the systemic circulation would increase. It would become a high resistance system. Is that clear?
Yes.
We'll be discussing the concept of parallel. You guys already have did it with Dr. Moad. You guys know better than me, but still I'm here to remind you things. Okay? Hello?
Yes.
So let's discuss our anatomy, right? So we discuss each and everything, like even each and every MCQ of you were here as well. Okay? So the next topic is going to be our heart anatomy. Before knowing, okay, Dr. Raihana, can you please fix your mic? There is some disturbance in that. Thank you so much. So the first topic is going to be heart anatomy. And before knowing heart anatomy, we discussed that you guys must be knowing the different surfaces and borders of your heart. So I'll be just writing down, you guys are going to be telling me. And regarding that, I'll be just making a scenario for you. You guys have to answer me. So first of all, who is going to be volunteer for this discussion? Please.
Yes, doctor.
Okay, Dr. Muskan is going to be, okay, volunteer.
I'm sorry, I couldn't hear very well. What's the first topic?
Hello? Hello? Okay, so now we are discussing heart anatomy. We discussed entire embryology. I think you weren't, okay, were you there? Hello? So we have finished the entire embryology along with all of the UWorld MCQs, and now we are discussing heart anatomy. So the first topic is going to be like, which structures make, like different surfaces of your heart. So Dr. Muskan have volunteered for the discussion. So Dr. Muskan, I'll be writing down, okay, anterior surface is made by which structure of your heart?
Doctor, your voice not clear. Hello?
Right. And
Hello.
Yes, now I can hear you. Anterior by the right ventricle. Anterior RV.
Okay. It's
Yeah.
formed by the right ventricle.
Yes.
What about your posterior surface of your
Left
heart?
atrium.
Ventricle.
Left atrium. What about the inferior?
Inferior one by the 2-3 of left ventricle and 1-3 of right ventricle.
Yes.
Okay. So can I write the both right and left ventricle?
Yes.
Yes. Inferior.
Okay.
2/3 left, 1/3 right.
Okay, perfect. So let's discuss some of the MCQs regarding these topics, right? So I'll be asking you MCQs, Dr. Muskan, you have to answer me that. We have an individual, he had a stable injury between third and fourth, like usually you can say third or fourth intercostal space. We discussed this MCQ a lot of time. So I think all of you guys know that, right? So he had a stable injury directed medial towards the sternum. Which structure of heart is going to be damaged?
Right
Punctured.
ventricle.
Right
Perfect.
ventricle.
If the same is directed laterally towards your sternum, which structure is going to be affected?
Lungs. Lungs.
Left lung. Perfect. Perfect. If we have same stay-bound injury, that is at mid-clavicular line, fifth intercostal space, which structure of your heart is going to be damaged? All of these three are your liver damage. Yes.
Your voice
You're
not
not clear.
Dr.
Right
Ahmed.
Hello?
Dr. Ahmed, your voice not clear.
Lungs.
Okay. Is there some problem with my voice?
Could you please repeat?
The
Yes.
mic.
Yes,
please.
doctor, we didn't hear.
Just give me a
It's
second.
breaking.
Let me
It's
fix it.
breaking. Yeah.
Hello? Can you guys hear me?
Yeah, it's
Yes.
better.
Yes.
Okay. So I was just telling you guys, if you have an individual, he had a stay-bound injury that is at mid-clavicular line, fifth intercostal space, which structure of your heart is going to be
Left
punctured?
ventricle. Left
Left
ventricle.
ventricle, apex of the ventricle, right? Apex.
Yeah.
Perfect. We have an individual, he was having, mitral stenosis. As a result of that, we were having, compression of esophagus. Okay. He was having dysphagia, right? If I want to take pictures of heart doing transesophageal echocardiography, so where should I approach, in the esophagus, till which level I should just come, and my camera, orientation should be towards which aspect of heart?
Posterior aspect of heart.
Left atrium.
I mean,
At which
yes.
level of, I'm
Yes.
just asking which level of,
Mid
till which level
esophagus.
of,
Yes.
If we camera interior, it will see the left atrium. If
if you just
posterior, this
rotate the
descending
camera
out.
180-degree, it's going to be your descendant. That's perfect. Okay. So it was all about the anatomy. Okay, we have an Ortner syndrome. What is Ortner syndrome?
Doctor, you were lagging. Could you please repeat
Hello?
the hoarseness part, please?
Okay. So, okay, I was just giving you a scenario. We have an individual who was having mitral stenosis, right? As a result of that, he was having dysphagia. Can you guys just give me a better explanation of that? Why?
Yes, because mitral stenosis, dilation of left atrium, so it will compress the esophagus, leading to dysphagia.
Okay. So, in order to take pictures of posterior aspect of your heart, right, we have to undergo transesophageal echocardiography. And in that, we have to, come till the mid-esophagus part, and we have to take picture of the posterior aspect of heart. So it's going to give us picture of which part of your heart,
Left
which chamber
atrium.
of your heart.
Left atrium.
Left
atrium.
There's going to be your left atrium. Perfect. So this was what we were discussing. Okay. So then we have pericardium, right? So pericardium basically is the outermost covering of your heart. It has 3 layers. Okay. So the only important thing which you guys should know, the nervous supply of pericardium, right? So can you guys just tell me the nervous supply of your
Phrenic
pericardium?
nerve.
Phrenic nerve.
Phrenic nerve.
Phrenic nerve. That's very important. Okay. And phrenic nerve also supplies your diaphragm as well, right? Here is a mnemonic that is C3 and C4, C5 keeps your diaphragm alive, right?
Diaphragm alive.
So keep that in mind.
Yes.
Yes. So the next topic which we are going to discuss
Can you
is,
please write it?
okay, the mnemonic.
Mnemonics. Doctor, you said something about Ortner syndrome. I didn't understand.
Okay, the Ortner syndrome is quite easy. For example, if this is your heart, the posterior aspect of your heart, that is your left atrium. If you have mitral stenosis, it's going to enlarge. It's going to compress your esophagus, and along here we have a nerve, which is left recurrent laryngeal nerve, right? Am I right? Hello?
Yes. Yes. Right.
Yes.
And due to compression of left recurrent laryngeal nerve, we can have Ortner syndrome. That is hoarseness of voice, because these they supply the muscles within your voice box, or you can say okay. So it's basically known as Ortner syndrome. Is that clear?
Can you please write what's Yeah. the spelling? Otna. Is it H or
ORTNER.
Is that clear now?
yes?
Okay, perfect. So the next topic which we are going to discuss is coronary blood supply. So we all, okay, I'll be just simplifying it. This is your aorta, your right coronary circulation, left coronary circulation, your LAD, your left circumflex, right? Coronary circulation. It was your LAD. LAD is going to supply which papillary muscle? High yield anterior lateral, right? Then you have PDA. In 80%, PDA is going to arise from right coronary artery supplying the inferior aspect of your heart, right? Okay, and AV nodal artery also comes from PDA. Okay, in the remaining 20% of individual, basically the PDA comes from left circumflex branch of your left coronary artery, right? Supplying the inferior surface. And in the remaining individual, it's going to be co-dominant, right? Both coming from your left circumflex and right coronary artery. Is that clear? So this was the concept of dominance. Is that clear? Okay.
Yes.
Then we have, okay, so let me just ask you a question. We were having, okay, a scientist just took blood samples from various portions of the body, from the arteries, and he compared it with such a place inside your body which were having the least amount of oxygen present. What the structure?
Coronary
Which,
sinus.
Coronary
Coronary
sinus.
sinus.
it was same kind of MCQ somehow, same kind of MCQ here you were right. That is coronary sinus. Why? Because normally at normal, heartbeat, your heart is like metabolically an active organ. Even like at the basal rate, it would just extract 60 to 70% of oxygen from your blood. Is that clear?
Yes.
Yes.
Okay, so with that we have finished
Dr.
our
Ahmed,
anatomy.
sorry, what was the question?
Okay, so the question was that we were having scientists, right? We took blood samples from various parts in your body, right? From the arteries, and he want to know that where within the body we have least concentration of oxygen or least concentration of oxygen present in the different structure, right? So that is coronary sinus. Or what was the highest difference of arterial, blood concentration with structure? Like that was a question like that. And the answer for that is coronary sinus. Why? Because coronary sinus is having the least oxygenated blood present inside your body, because heart is metabolically an active organ and it keeps on extracting 60 to 70% of blood even at normal beat. That's why the blood which is leaving your heart, the deoxygenated, is going to be the most deoxygenated blood present within your body. Is that clear?
Yes, thank you.
Yes.
Okay. So let's discuss. Okay, so with that, we have finished the anatomy. Now we'll be discussing the physiology, right? So we'll be going through the physiology. Okay, just give me a second. Okay, so let's have 5 minutes of break before starting the physiology, right? Is that clear? Hello?
Yes.
Yes.
Yes, sir.
What
Let's have
will be
5
the
minutes.
first topic on physiology?
The first topic, as I have already
volume.
mentioned, you guys have to open your first aid book in front of you. So the first topic is going to be stroke volume, right?
Stroke volume. Okay.
Yeah. Thank you so much.
Thank you.
Yes, we're on break.
Thank you.
Hello? Hello, can you guys hear me? Hello?
Yes, Doc.
Yes.
Yeah. Yeah.
Okay, that's perfect. So let's proceed our discussion further. And we were discussing physiology, right? So let me just share my screen again. Okay, perfect. So the first topic which we are discussing is stroke volume, right? And regarding the stroke volume, we know what is stroke volume. In order to simplify it, the volume of blood which is leaving your heart in a single beat. Once your heart beat, some volume of blood is going to be moved into aorta. That's simply your stroke volume, right? Hello? The stroke volume is the amount of blood which is leaving your heart in a single beat. Is it clear?
Yes.
Yep. Yes.
Perfect. Like for example, this is your heart, your aorta, and your heart is beating. So the amount of blood which is leaving in the aorta in a single beat, that's simply your stroke volume. Okay, so there are certain factors which affect stroke volume, and that would make a lot of sense to you guys as well. For example, if I keep on beating the heart with stronger forces, what do you think? Won't greater volume of blood leave in a single beat now?
Yes.
Yeah.
Yes.
That is whenever the power or contractility increase. So what happens? Stroke volume increase. Can I say that?
Yes.
Yes.
Perfect.
Yes.
Whenever the preload increase, according to Frank Starling, more overlap of actin and myosin filaments. If you have more overlap of actin and myosin, again the contractility is going to increase. So what would happen to the stroke volume?
Increase.
Stroke
Increase.
volume increase. But what if afterload? You know,
Decrease.
afterload is basically the force against which your heart is beating, right? So it's basically determined by your arterioles, right? So if the arterioles are constricted, the resistance is high. The afterload is high. If the afterload is high, now it's difficult for your heart to pump against higher load. So whenever the afterload increases, the stroke volume
Decreases.
decreases. Keep that in mind, really important, very high beat, okay? So these were the things which you first have discussed. And besides that, okay, so stroke volume is the work done by ventricle and ejecting the stroke volume. We already discussed that. If your heart is failing, if the power of heart is decreasing, the contractility is decreasing, what happens to the stroke volume in heart failure?
Will decrease.
Decrease.
It would decrease. Okay, so the next topic which we are going to discuss is contractility, right? So we already discussed contractility is basically, you know, the amount of force or the power which your heart is generating. So contractility is, dependent on a lot of factors. That is, whenever we have beta 1 stimulation, it's going to increase the calcium inflow. And whenever we have more calcium, we know more calcium leads to more overlap of actin and myosin filament. And if we have more overlap, more force is going to be produced. So the pathway here, the phospholimin and everything, you guys have to memorize that. But in the end, you should note that increased calcium lead to increase actin. Just write it down on your first aid, right? It's a summary of all things. You don't have to memorize the phospholimin and the pathway, phosphorylation and things. You should just give it a read, but you should know the main concept what they are telling you. Whenever we have more calcium influx into the cardiac myocyte, it would increase the actin and myosin filament overlap. And if we have more overlap, if we have more people, exerting force, so the contractility is going to increase, right? Is that clear?
Yes.
Okay.
Yes.
Then we have a drug that is digoxin. Okay, so we know the function of digoxin. We already discussed that. It's going to inhibit your NAK plus pump, and in the end, again, the calcium is going to rise, right, within the cell. What's the end result of digoxin? Increase intracellular calcium.
Increase in contractility.
So again, the same explanation. More calcium, more actin and myosin filament overlap, more contractility, more stroke volume, right? Hello?
Yes.
Okay, perfect. So similarly, if you want to decrease the contractility, we have to decrease the beta 1 stimulation by catecholamines. Similarly, the calcium, we can give calcium channel blockers as well, non-dihydropyridine calcium channels, which basically acts on your heart more, right? So it's also going to decrease the calcium, decrease the contractility. Similarly, hypoxia and hypercapnia can also do that. If you have less oxygen, more carbon dioxide, less perfusion, it can also, decrease the strength of your heart, decrease contractility. Is that clear? So what is preload? For example, if this is your heart, preload is the amount of blood which is coming into your heart, amount of venous blood. So if you have more preload, contractility is going to increase. That's simply Frank-Starling mechanism. Is that clear? So for example, if I'm giving an individual a venoconstrictor, what would happen to the preload?
Decrease.
Decrease.
Increase.
If I'm constricting the veins, it means I'm pushing all of the blood into the heart. If I'm pushing all the blood into the heart, the preload would increase. And as the preload increases, according to Frank-Starling, the contractility increases, the stroke volume increases, right? On the other hand, if I'm constricting the arterioles, then what would happen to the cardiac output or stroke volume?
Decrease.
Decrease.
Reduce. Decrease.
So the drug, which is basically hydrolysine, it would vasodilate the arteries, it would decrease the afterload. If the afterload decreases, stroke volume increases. You already know that, right? What happened in hypertension? Same thing. Constriction of your arterioles, which is going to increase your afterload. Is that clear?
Yes. Yes.
Okay, so if the heart is pumping against higher load, there is going to be some adaptation within your heart. What's that?
Hypertrophy.
Okay, would it be a concentric hypertrophy or eccentric hypertrophy?
Concentric.
Concentric hypertrophy. Because the main goal is going to be like your heart is going to lay down more muscles in order to pump against these higher loads, and more muscle lay down occurs in concentric hypertrophy. Okay. Similarly, if you are giving an individual ACE inhibitors and ARBs, right? So we know that angiotensin to constrict your arteries, right? So if you are giving an inhibitor, what would happen to the afterload then?
Decrease.
Decrease afterload. Okay, so that's the thing you should just keep in mind. But the preload also decreases with that. Why? Because we are also inhibiting, we won't be seeing formation of your aldosterone as well. If aldosterone isn't formed, we cannot, reabsorb more water. So more water isn't reabsorbed, so the preload is also going to decrease. Is that clear? So both the preload and afterload is going to decrease. Is that clear?
Yes.
Okay, perfect. So the next topic which we are going to discuss is...
Hello.
Yes, please.
Yes, Dr. Ahmad. Sorry, just we got clear about the periload and venous. Okay, but what about the afterload and arteries? You have said something. It was I just missed it. Can you again repeat about afterload and artery connection when you are constructing?
Okay, so this is your heart. These are your veins, which are basically feeding blood into your heart. And you have aorta, and aorta lead to arteries, right? And arteries have arterioles. That are the switches, right? So if I'm constricting the veins, what happens to preload? Preload would increase. Why? Whenever I'm constricting, it means I'm pushing all of the blood into your heart. If I'm pushing a lot of blood into your heart, preload increases. And as the preload increases, according to Frank-Starling mechanism, there will be more overlap of actin and myosin filament. More overlap is going to lead to more contractility and more cardiac output of stroke volume. Is that clear?
Yes, yes,
Okay.
this part is clear.
But if I'm constricting your arteries, what happens to the resistance?
Increases.
If the resistance increases, can I say the afterload also get increased?
Yeah, it increases after load.
So now your heart is going to pump against more force, more load. So what would happen to the stroke volume?
Decrease.
Decrease. Okay. Similarly, if I'm vasodilating your arteries, what happens to afterload? Decreases. If the afterload decreases, now your heart have to push against less force, less blood, sorry, less resistance. So the stroke volume is going to increase, right? And the drug which basically dilates your arteries are going to be your hydrolysis. If I'm dilating the veins, what happens to preload then?
Reduces.
Reduces. If the preload reduces, what happens to the contractility? Reduces, contractility decreases, stroke volume decreases, and cardiac output decreases. Is that clear?
Yeah.
Yes.
Yes.
Yeah.
Shall I just move forward?
Yes.
Okay. Dr. Nahid, is that clear?
Yes, that side is when it is increased, the same side, the other side also will be increased. They are very direct connection. You mean
Excuse
the
me, sir.
afterload? Sorry,
Yes.
that is
Sir, like you gave the simple definition for preload. Like, can we have just 4-word simple definition for the afterload? Because afterload is confusing.
Okay.
that is also my
Afterload.
question. Yes.
Okay. Afterload is the, okay. Let me just give you a simple example, right? Here you have a bodybuilder, let's suppose, okay. And, this bodybuilder have a bucket of blood, okay. And he have to push it against this window, right?
Yes.
Hello? And in this window, for example, if I have closed this window, it would be hard for this bodybuilder to, push the blood against closed window, right?
Yes, sir.
So this window, this closed window, it's basically the amount of load against which your bodybuilder, or in this, your left ventricle is acting. That's the afterload. Is that clear?
Yes,
Or
sir.
simply you can say, now this, if I'm just putting a lot of dumbbells, 20 kg dumbbell here, right? First of all, like this, your bodybuilder is easily going to lift it up. But if I'm increasing it to 80 kgs, if I'm increasing the load, it means you can see I'm increasing the load, right?
Yes.
So this is after load. What is after? After means, okay, you should just like look towards the words, right? After load. What is after? After the heart comes your aorta, right? The load which is present within the aorta, the amount of force or the amount of energy required for your left ventricle to push things against aorta is your afterload. If this window is open, now it will be easy for me, for this bodybuilder to push that blood against the open window, right? So here the afterload is decreased. If the afterload is increased, you can easily push blood. So if you can easily push blood, the stroke volume can be more. Is that clear?
So basically the afterload is increased by the already much amount of blood present in the heart.
Sorry?
So like afterload, like you say that the load is increasing. So basically the afterload would be more if already more of the blood is present in heart, and now pushing against that is difficult.
Okay, it has nothing to do with heart. It's afterload. It's after the heart. Okay? After the heart. Now, okay, Okay, let me just give you another example, right? So, okay, so let me just give you an example. For example, again, we have a bodybuilder here, right? And again, he have a bucket of blood or water and he's just pushing it through this window. For example, if this window is open, it would be easy for him to, get all of the blood into the systemic circulation, right?
Yes.
Okay, if we have dilation, what happens to resistance?
Decreases.
Decreases.
Resistance decreases. Resistance and afterload are same things.
Okay.
Okay.
Okay, if the resistance decreases, it means afterload decreases, right?
Yes.
So it's easy for him to push blood against the open windows, decrease afterload. If I just close this window, right, decreases the width of this window. Now what happens to resistance?
Increases.
What happens to afterload?
That will also increase.
Okay, so resistance is your afterload. Resistance, the force, the load, it's a load. If I'm increasing the resistance, it means the force here is all of this increased resistance force is experienced by this bodybuilder. Because now he have to apply more forces. So more force application means that here there is a more load, right? More load.
Yes.
Is that clear? So resistance is equal to
Sir, I have a
afterload.
question.
Load.
Hello?
Yes, please.
Yeah. If someone has high blood pressure, this means that his afterload is increased when his resistance is increased.
Yes, yes, yes.
Yes.
If we have hypertension, it means that all of the blood vessels are constricted, right? It means the resistance is high. So if the resistance is high, afterload is high. So what happens to a stroke volume? Just imagine that you are standing there. Stroke volume decrease. It's difficult for you to push, like the blood against these closed vessels. Is that clear?
Yes.
Any questions?
Yes.
Okay. So let's move to our next topic, that is cardiac oxygen demand. So that's very simple, right? As I'm using muscles more using of muscles required more oxygen. It required more nutrients. Is that right?
Yes.
Hello?
Yes.
So I'll be giving you
Yes.
some questions you guys have to tell me. We have an individual, he's having hypertension. What do you think the cardiac oxygen demand would increase or decrease?
Increase.
Increase.
Why?
Increase because they're
more
need of
resistance
force.
Because we have
Because
more
afterload is
resistance.
increased.
Because we have more resistance in hypertension, we have more afterload. Now your heart is going to act against more load. So if heart is acting more, it needs more oxygen. Does that make sense?
Yes.
Yes.
If the contractility increases, what would happen to cardiac oxygen demand?
High.
Increase. Increase.
Contractility again is more power. More power need more oxygen, more fuel, right? Oxygen is your fuel.
Yes.
Okay. If the diameter of the ventricle increases, it's basically, this concept is basically, marking you towards Frank Starling. More diameter mean more preload. More preload mean more overlap. More overlap of actin myosin means more contractility. If we have more contractility, what would be the fuel consumption?
More.
More. And fuel is your oxygen. So the cardiac oxygen demand increases. Is that clear? So you don't have to look toward the formula, the Laplace law. You don't have to confuse yourself. These are some
Doctor,
simple.
I have a question in my mind. So in the dilated cardiomyopathy, so the circle is very big. Like the series, it's added in series. The lumen is very big. It means that the preload increase and everything gonna increase.
Mm-hmm.
The ejection fraction also gonna increase in the DCM.
Okay, so what's the question
Not
that
necessary.
in dilated cardiomyopathy, yes, the diameter of ventricle increase. So what's your question?
So the preload is gonna be increased in the DCM.
Mm-hmm. But you are saying
And
that,
since the preload is increased, you said the contractility, the coupling mechanism will contract more. forcefully. That means like they contract more forcefully, and the afterload will, the ejection fraction will be increased. The stroke volume will also be increased because it's gonna pump the blood more forcefully.
Okay. So the answer for that question lie in your name. It's cardiomyopathy.
Hmm.
Does it make
Okay.
sense?
Yeah.
It's not a normal
Yeah.
condition. It's a
Yeah. Okay.
cardiomyopathy, right? Your
Mm.
heart,
Mm.
like simply you can imagine whoever is exerting the force, yes, the mechanism, you can apply that mechanism, but to normal people, you cannot apply it to abnormal people.
Okay. Mm.
You cannot apply it to a cardiomyopathic heart, cardiomyopathy, pathology. There is also already a pathology. Is that clear?
Yes.
Okay, perfect. So let's move to our next topic, which is, okay, stroke volume. So, what's the equation for stroke volume? For example, if you have end-diastolic volume, now some of the volume is going to enter into your aorta. That is going to be stroke volume. In the end, we have, okay, it's end-diastolic volume. And in the end, once if it give like this amount of blood in every beat, the stroke volume, so the remaining amount is going to be called as end systolic volume. So how to calculate stroke volume? Stroke volume is equal to end diastolic volume minus end systolic volume. Is that clear?
Yes.
Yeah. Perfect. So, okay, what do we mean by ejection fraction? As the name indicates, the amount of blood or the fraction of blood which is ejected. Ejection fraction. Can I say that?
Yeah.
Yes. Yes.
So what is so you can just only like looking
Inject.
towards the name, you can just know the formula, right? So we have end diastolic volume at the end of diastole. So for example, if this amount of blood is, or this fraction of blood is ejected from the end diastolic volume, it's going to be your ejection fraction, right? So can I say that ejection fraction is equal to stroke volume, because the amount is stroke volume, that, divided by the total. Can I say that?
Yes.
Yeah.
And
Yes.
can I just put these values here? Because we know that ejection fraction, the stroke volume also equal to end diastolic volume minus end
Yes.
systolic volume divided by end diastolic volume, right? So these are the formulas which you should just keep in mind. So the next formula which we are going to discuss is fixed principle. So who is going to be telling me what's fixed principle? Dr. Moaz have already explained everything in quite detail and quite great. So I'm expecting from you guys a lot. Yes, what is fixed principle? Guys, be quick. We have to cover a lot of things.
A fixed principle is basically it's about cardiac output. It's a ratio between the rate of oxygen consumption divided by the difference between the arterial oxygen content and the venous oxygen content.
Okay, this is something which you have memorized, right? So I need the concept. The concept is simple, right? We have an individual. I want to calculate his cardiac output. How do I do that? I'll just check his arterial blood, oxygen concentration, his venous blood, oxygen concentration, right? Hello?
Yeah.
Yes.
Okay, so the arteries are going to supply to your organs. We know that, right? And the organs are going to give all of the deoxygenated blood into your veins. So if I just subtract it, the arterial O2 from the venous O2, won't it give me the amount of oxygen consumed by your organs or
Yes.
tissues? That's simple. And now I would just calculate the amount of oxygen which this individual is taking in, right? So I'll just take a ventilator, for example. So if I know the amount of oxygen which this individual is consuming, right? If I know that how much oxygen this individual is consuming per minute, so I can find out cardiac output. What I have to do is I have to take this blood, I have to take the amount of oxygen which is consumed, amount of O2 consumed, divided by, this amount of oxygen consumed by your organs, right? That is arterial O2 minus venous. It's going to give me cardiac output. Is that clear? What is cardiac output? Cardiac output in the end is going to perfuse your organs, right?
Yes.
Yes.
So if
Yes,
I
yes.
know the amount of oxygen which individual is taking, and if I know the amount of oxygen, out of that oxygen, how much oxygen is consumed by the tissues, so I can find, so, I can easily calculate cardiac output. Does that make sense?
Yes. What would
Yes.
be the normal value of cardiac output in this equation?
5 liters.
It's 5 to 6 liter
Okay.
Okay.
per
Okay.
minute. There is
Perfect.
other methods also like Kitco, Pitco, and the temperature difference.
Yes.
Same
So.
the same concept there, you know, the change in temperature and Litco change of molecular difference between arterial and venous. And the simple is the fix principle. We have to know our measured amount of oxygen, what we deliver to the patient, and we take arterial blood sample and venous blood sample. Then we, put the values.
Yes, that's perfect. Like as Dr. Jamil is just pointing out towards another, what's that? I don't know. Pitco, what's that?
Litco and Pitco. This is the
Okay. But the
means
concept is same. The
yeah, the
concept
concept
is
is
same,
same.
right?
Yes.
The concept is same. Cardiac output is going to perfuse you. It's going to provide oxygen to your tissues. If you know the amount of oxygen which you are giving, and out of that, how much your tissues are consuming, you can easily divide it on one another. You can get cardiac output. Is that clear? Okay. So
No.
let's move to our next topic, that is
Dr.
pulse rate. Yes, please.
Yeah, this principle same is it similar to the equation of cardiac output being
Yes.
equal to the stroke volume times the
Heart rate, right?
peripheral, yeah.
Heart rate. Okay. What's the equation for cardiac output? Stroke volume into
Heart rate.
Peripheral resistance.
peripheral resistance or heart rate?
Heart rate.
Heart rate.
Could be heart rate.
Heart rate.
Okay. So it's very easy. If in the question they have given you the heart rate, if they have given you the stroke volume, so you're going to use this formula. If in the question they have given you something related to arterial blood pressure, venous, you would have seen that, right? An amount of oxygen consumption, you should use this formula. Both of them are going to give you your cardiac output, right? Hello?
Yes.
Yeah.
Okay. Yes. Okay, perfect. So let's move to
There
our
is
next.
the one MCQs. They asking about the cardiac index. When they ask the cardiac index is the same like cardiac output divided by total body surface area. Means in short word, it's they were asking about the cardiac output. There's one question regarding um, septic shock. Then they ask put the value with arrow up or down.
Yeah.
Means after
So,
load increase,
and the other
cardiac index.
MCQs was that they are going to give you arterial blood content, venous blood content, and what else we need to calculate cardiac output. So that is rate of oxygen consumption. Okay. Hello.
Yeah.
Dr. Ahmad, this equation I didn't really get it. This this last line on the screen. This equation.
This equation?
No, this.
Just give me a second. What happens?
She's talking about fixed principal equation.
Yes, that's
rate
fixed.
of oxygen consumption
Yes.
and arterial venous oxygen difference.
Okay. Okay. So, for example, if someone just appeared in a clinic, he want you to calculate his cardiac output. You're going to take this patient. Let me just make it very simple. Just remember the story, right? If you aren't getting the mathematical equation, most of the students, it's like quite difficult for them to get the mathematical equation. What you have to do, you have to calculate the amount of oxygen which he is taking in per minute. Let's suppose per minute he is inhaling, let's suppose 2000, volume of volume of your oxygen. You have to take that value. You have to take his arterial blood oxygen concentration, venous blood oxygen concentration. You have to take this value, that is oxygen consumption, and you have to divide it on the difference of both of them. Arterial oxygen minus venous oxygen. That's simple.
Okay.
Is that clear?
Yes.
Hello?
Thank you.
Okay, so that's everything which you have to know. Just keep it in mind. Okay, so the next topic which you are going to discuss is pulse pressure. What is pulse pressure? Who's going to be telling me that?
Systolic minus
The
diastolic.
difference between systolic blood pressure and diastolic blood pressure.
Systolic blood pressure minus diastolic blood pressure. Perfect. So that's going to be your pulse pressure. So there are certain conditions in which the pulse pressure increases. There are certain conditions in which, like we can, like we will be discussing that in a pathology section. But the one of the condition, aortic regurgitation. What happens in aortic regurgitation? Yes.
It increases.
Systolic pressure decreases.
Okay. So what happens in aortic regurgitation during diastole, blood is going to enter back into your left ventricle, right? So the diastolic blood pressure is going to decrease. And as the blood enters back during diastole, so here what happens? The end diastolic volume rises with the next beat, right?
Yes.
Hello?
Yeah.
So as we know, diastolic blood pressure is decreasing in diastole, but in the next beat, end diastolic volume increases. Frank-Starling mechanism says that stroke volume would increase, right? And if stroke volume increases, systolic blood pressure increases. So if the systolic blood pressure is increasing while the diastolic blood pressure is decreasing, what would happen to their difference? It would increase. So the pulse pressure would increase. Is that clear?
Yes.
What happens in aortic stiffening?
Diastolic increases.
Diastolic increases or systolic?
Diastolic decreases.
And aortic
Systolic pressure increases.
Systolic pressure increases. If we have closed or stiffened aorta, what happens now? The blood which is entering into aorta would exert more pressure, more systolic pressure, right? Is that clear?
I mean, lateral lobe becomes bigger.
Okay, so if
because
the systolic blood pressure is increasing, then diastolic, again, the pulse pressure would increase. Is that clear?
Yes.
Oh, okay, perfect. Similarly, whenever we have increased sympathetic tone, high output state, anemia, hyperthyroidism, what would happen to the pulse pressure?
Increase pulse pressure.
Increase pulse.
Due to
Yes, like
increased
as we are
systolic pressure.
having anemia, the blood is becoming more thin. You can simply imagine. So as a result of that, it's going to exert more pressure. It can easily, the viscosity is decreasing. So what happens? The pressure is going to be increasing. Similar in case of hyperthyroidism as well, right? So it would lead to increased pulse pressure. So the next topic which we are going to discuss is Starling curves.
Dr. Ahmed, just one point. In aortic stenosis, systolic blood pressure is going to decrease, right?
I'm just talking about aortic stiffening, not aortic stenosis. In aortic stenosis, pulse pressure is going to be decreasing, right?
Yeah.
Like if the stiffening means that you have hard, stiffened, non-elastic.
Aortic valve.
Yes, aorta. And the stenosis means you have thin aorta. There is quite difference in aortic stiffening and aortic stenosis.
So what did
right?
you tell about aortic stiffness?
In aortic stiffness, if the blood is striking the stiffened wall, the pressure is going to rise. Okay?
Will it
But
be
normally,
systolic component?
yes, the systolic component is going to rise. Okay? So, the next topic which we are going to discuss is Starling curves. So, Dr. Moaz already explained Starling curves in quite great detail, but I'll be just giving you guys an overview, right? What are Starling curves? You have preload and you have stroke volume. Whenever the preload increases, what happens to stroke volume? It would
Also
increase.
Dr. Ahmed, we can't see your screen. Are you sharing the screen?
Yes, I'm sharing the screen.
We
But
can't
cannot
see
see.
it since like the past 10 minutes.
Oh. No.
Yes, now it's okay.
I was just sharing my screen. I just draw all of these structures, everything, and stiffening and everything. Okay. So now let's discuss Starling curves. So we have preload and we have stroke volume. According to Frank-Starling mechanism, we know whenever the preload increases due to high overlap of actin and myosin filaments, stroke volume is supposed to increase, right? But this curve can shift towards this side or this side, right? So what happens that if the curve is shifting like that, What do you guys assume?
Heart
It's
failure.
on the right
If
side.
going down,
It's
then heart
contractility.
Heart
yes,
failure.
hemorrhage.
Stroke volume.
Stroke volume
Okay.
reduces. So
So
heart
there is heart failure. There can be decreased cardiac contractility, and if the the graph is going towards the left, what do you guys assume then?
Now contractility decreasing, so stroke volume also decrease.
during
Okay.
exercise. Exercise.
Or
Or
during normal
hyperdynamic state.
So whenever you have a UL MCQ on that as well, like basically here you guys can see, let me just overlap these curves here, right? So you guys can see in this case, like with a constant preload, like the preload in both of these points are constant, but the stroke volumes are different. So whenever at a constant preload, if the stroke volume is decreased from this point, from point 1 to point 2, it means something is wrong with your heart, right? Heart isn't pumping well with a constant preload, right? And again, with the constant preload, if the stroke volume is increasing from this point to this point, it means now your heart is exerting more force. The preload is same, but the force is more. So it have to do something with intrinsic nature of heart. Are you guys getting me?
Yes.
Okay. So you should just keep that in mind. Whenever we have right-sided shift of the curve, there is some problem with the heart. When we have left-sided, it means we have increased the ability of heart, that is contractility, right? During normal exercise. Is that clear?
Yes.
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 Okay, so the next topic which we are going to discuss is resistance, right? So the resistance topic is very simple. So we have two kinds of resistance, series resistance and parallel resistance. So for example, if I have resistance 1 in series, resistance 2, resistance 3. So what happens? What would happen to the overall resistance? We are going to add them, right? So overall resistance is going to increase. Okay, so what do we mean by parallel circuit? You should just keep that in mind. For example, if this is your heart, right? Parallel circuit means that, okay, so this is your circuit 1, circuit 2, and circuit 3. So this is going to be resistance 1, resistance 2, and resistance 3. So in the parallel circuit, you should just keep in mind, each of the resistance is being supplied by the source. You can see it here, right? So R1 is directly being supplied by the source, that is your heart. R2 again is going to be supplied directly from the source, that is your heart. R3 directly is going to be supplied from the source, that is your heart. Are you guys getting me? It means that whenever I'm adding more resistance in a parallel circuit, it means I'm increasing the pathway for the blood to flow. Does it make sense?
Yes. Yes.
So what will, if I'm in the parallel circuit, if I'm adding the resistance, if I'm adding the pathways, it means the overall resistance would
Decrease.
decrease, right? So now, like for example, if I'm adding one resistance, you have one path for the blood to flow. If I'm adding two resistance, now you have two paths for the blood to flow. If I'm adding three resistance, now you have three paths. So if you have one path, it's difficult for the blood to flow there. If you have two paths, now some of the blood can flow here. So the resistance decreases. If you have three paths, now the blood can flow in all three paths, and the resistance further is going to decrease. Is that clear?
Yes. Yes.
That's perfect. Okay, so let me just give you an example. We have an individual, we amputated his leg. What happens to the cardiac output?
Decrease.
Reduce.
Can you please fix your mic? There is some noise. Okay. So my question for you guys is, question of the day. We have an individual, we have amputated his leg. What happens to cardiac output? Increase or decrease?
It should decrease because
It's decrease.
the resistance is decreased.
Is less. Yeah.
Yes, who is going to answer me? This question with explanation, I'm going to avoid it.
Well, since the resistance, the overall resistance decreased, that means there's no longer any need for pumping the blood, more blood into the system, so it should decrease.
I think because
I
now
think
we
cardiac output will decrease.
total resistance, it should increase. If total resistance increasing, it means CO should decrease, cardiac output.
Okay, perfect. So actually, whenever okay, just keep in mind all of the body parts are attached in a parallel circuit, not in a series circuit, right? So in the parallel circuit, if I'm removing the leg, if I'm removing the resistance, what happens to overall resistance?
Increase.
So the overall resistance increases. If the resistance increases, what happens to afterload?
Increase.
So afterload increase, what happens to cardiac output?
Decrease.
Decrease.
After all increase, so cardiac output decrease.
Is that clear?
Dr. Ahmed, can you please explain this parallel circuit thing again? I didn't get it.
Okay, so for example, if this is your heart, right? So your heart is basically providing, like that makes sense. For example, if I have my legs, right? So legs is directly receiving blood from your heart, right? Or not? Leg is going to, the blood is first of all going to go to your arm, then it's going to go into your liver, into your kidney, into your GIT, and then into leg. Is the pathway number 1 correct or pathway number 2 correct? Hello?
What's the question?
My question is that, is your leg directly receiving blood from your heart, or first of all, the blood is going to go into your arm, then into your liver, then into your kidney, then into your, small intestines, and then it comes to the leg. Which pathway of the blood
Pathway
is?
1.
Pathway 1 is correct. So can I say that it's a parallel pathway?
Yes.
Yeah. Okay. So as we discussed, it's your heart and every organ is attached in parallel because every organ is directly receiving blood from your heart. And in the parallel circuit, if I'm increasing the resistance, it means I'm increasing the pathways. Increasing the pathways, right?
Yes.
So what if I'm increasing the pathways? So what happens to the overall resistance?
Decrease.
I have more paths for the blood to flow now. Overall resistance would decrease. Is that clear now?
Yes.
Hello?
Yes.
Yeah.
I'm sorry. If you increase the pathways, the resistance increases, right?
Resistance decreases. Idea is very simple. Okay.
If you
For
increase
example, let me just give you example. I have 10 cars.
Increase the pathway resistance.
Let me just give you an example, please. I have 10 cars and I have a single road for that. Would it be okay? And all of these 10 cars want to go through this road. It would be difficult for them, the car, to pass through this road, or easy for them?
Difficult.
If I'm just increasing the path, so now 5 can go here, 5 can go here, right? So now I'm just making easy for these cars to go, right? I'm increasing the pathways. Right?
Yes.
Dr. Hana, can you please fix your mic? Okay. If I'm further increasing third path, so now the cars can easily pass. Three can move to this, 3 can move to that, and okay, so 3 here. So like 4, you can say 4.5, something like that. So as I'm increasing the pathways, what happens to the overall resistance? The easiness of the cars to move through the roads. That's resistance, right? The resistance overall decreases, right?
Yes.
Yes.
Does that make sense?
Yeah.
So same is the case with heart. If I'm adding resistances, it means I'm adding different pathways for the blood to flow. So the overall resistance is going to be decreased. Is that clear?
Yes.
Yes. So overall resistance once it decreases, then what happens?
If the overall resistance decreases, the afterload decreases. Okay.
So the stroke volume goes up.
So, okay, let me just give you another example. We have a female. She got pregnant. Okay. We have a female. She got pregnant. What happens to her total peripheral resistance?
Decrease.
Decreases.
Why?
Because the fetus
Because the
and
preload is high.
parallel circuit.
Yeah, a new parallel circuit
Yeah.
added. That is
Because
the
we have a new parallel circuit.
Yeah.
Is that clear? I'm
Yes.
adding fetus into a parallel circuit. It's receiving blood directly from your heart. If I'm adding the fetus into a parallel circuit, it means I'm increasing the pathway. I'm adding an extra path for the blood to flow. If I'm
Yeah,
adding
I
an
got
extra,
it.
so
I
what
got it.
happened?
But
The
so
overall
resistance
resistance
decrease.
will decrease.
Decreases.
If resistance decrease, it means what happens to systemic vascular resistance? Decreases. You have a UL MCQ on that.
Yes.
Does that make sense now?
Yes.
Let's discuss another scenario for you guys. The resistance in the trachea is more or resistance in bronchioles are more. That's also your UL MCQ.
Trachea.
Bronchioles.
The more small diameter, the more will be resistant.
Bronchioles. Like in arterioles,
No, as the
The small radius, the more
airway goes
resistance.
divided, the resistance will be decreases.
Okay,
The
where
max
are you going to have most resistance in your pulmonary, in your arterioles, not arterioles.
arterioles.
Yes, arterioles.
Okay, you guys aren't getting me. Please just let me speak, then you guys can answer. I am asking, the resistance within the trachea is more or resistance within your arterioles?
Arterioles.
arterioles.
Yeah.
Okay. Let me just, okay. Trachea is a single structure, right? Arterioles are million. So the resistance in these million pathways are going to be more on this single pathway.
single pathway.
Single pathway. So the trachea will be more.
So why are you just telling? I was just telling you arterioles, not arteriole. Does that make sense?
Because we were thinking related to radius and resistance. We forgot about the parallel and series.
So you weren't actually, listening to me. I was talking about arterioles, and I was just emphasizing on that S. Right? So there's your UL MCQ on this concept as because in
Can
case
you
of artery.
can you please repeat this?
Okay.
I'm sorry.
Also, on first aid, it says arterioles account for most of the total peripheral resistance. Then what does it mean?
Okay. Not arterioles, that are bronchioles. So yeah, okay. In case of lungs, bronchioles, not arterioles. Okay. Like bronchioles can be also called as arterioles in case of like you can just enter change those wordings. Okay. So as we know that bronchioles are like, for example, if the blood, if the air is entering, so it's a single pathway for the air to flow. Then you have millions of pathways for this air to flow. If you keep on adding, the overall resistance of these parallel pathway is going to be way more. It's going to be way less, very less, right? Because you have millions pathway for those air to flow. So the air can easily flow to these bronchioles, but it would be difficult for them to flow through the single trachea because it's a single structure and there are million of structure. And again, it's a example of a parallel circuit. Same trachea, like giving air to million of pathways. It's an example of parallel circuit, right?
Yeah.
Yeah.
Does that make sense? So I gave you 3 examples. Amputated leg, I gave you an example of a pregnant woman, and I gave you an example of your respiratory system. Also, everything is clear now.
Dr. Ahmed,
Yes, please.
what about the reward of the amputated leg? I answered you. You said
Yes,
new.
I'll just give you the reward. You don't have to reward. So 5 of your questions in your, I'll just mark 5 of your questions in your assessment as correct. Okay, if you just get it wrong. So you have, you are more like 5 points higher than all of the other one. Okay.
Okay, thank
That's your reward. Okay. And those who scored well, I'll be sharing the report. So you must be, prepared for that. Okay, I'll be giving, okay, let me just announce a giveaway. Those who scored, okay, for the top 2 students in this assessment, I'll give them a free giveaway of research. Okay?
Then we need a day to prepare the test.
Free giveaway, you guys can just, get into the research free. Okay, we'll be
Doctor,
starting our.
When is the assessment? Today?
Yes, now you guys are interested in taking assessment. Okay, so the assessment is going to be today. You have 24
Hey,
hours for that.
we've not
Yes, you have
finished.
20. You have. We are going to give you one assessment as well as a task as well. So first of all, you guys have to do the task, then attend your assessment. Okay, and from tomorrow onwards, you are going to start endocrinology. 24 hours. Okay.
Doctor, did we finish the boot camp?
When are we going to finish the boot camp?
Yes.
The,
I thought
okay,
we didn't do
once the topics are done, so then we are going to finish the boot camp.
Okay, Dr. Ahmed, I have a question. Will it still
Yeah.
be open from now till tomorrow? How many hours
Like
is
I'll
there?
just okay, you have 24 hours. So I'll just after this session, right after 2 hours, you can just I'll just send you the schedule. Just do that schedule, and those 2 hours try to cover that up. And after that 2 hours, you can count 24 hours.
Okay, okay. That means it will still be open till tomorrow. Thank you.
Yes.
All
Okay.
right, bye. All right,
So
bye.
free research giveaway for those who first two students who have scored. And you guys don't have to use ChatGPT or something like that, okay? Because it's going to mark your question, incorrect. You guys won't score. And I know who uses ChatGPT. I'll just put some MCQs there who are going to be different than that. So you don't have to use some, extra things. Just keep that in mind, okay? So for the first two students, free research giveaway, okay? So let's discuss our next topic, ionotropy, venous return, and total peripheral resistance. I think we already discussed that. That's very simple, right? Hello?
Yes.
You guys should just read it, okay? It's your task. We already discussed everything. We know the concept. So you guys should only just go through this, okay? So the next topic is going to be your PV loops, pressure volume loops. We discussed different phases of your ventricular contraction, right? So let me just draw this loop for you guys. First of all, your left ventricle is going to be filling, right? So this is going to be the filling phase. So here you have your left ventricular volume, and here you have your left ventricular pressure, right? So as we are filling your left ventricle, so the volume is going to increase. And in the end, we are going to have end diastolic volume, right? And as we discussed, your left ventricle is then going to contract in a form of closed chamber. Remember?
Yes.
So as we are contracting in a form of closed chamber, what do I mean by in a form of closed chamber? That initially, once the systole began, both of your aortic and mitral valves are going to be closed. So your heart is going to contract in a form of closed chamber. And as it is contracting in a form of closed chamber, it's basically the volume do not changes, but the pressure increases, right? We already discussed that. So it's going to be isovolumetric contraction. That is, the volume is going to be constant here while the pressure is increasing. You guys can see it here on the graph, right? And a time would come that this pressure would increase, or it would over exceed the pressure of your aorta, and your aorta is going to open, right? And once your aorta opens, it's going to produce which sound?
S.
As open, no sound.
Oh yeah, opening no.
Yes,
No
that's
sound.
perfect. So opening of the valves do not produce any sound, okay? Closure of the valves produce sound. Thanks God, you guys are, awake. Okay. So what happens as your aorta opens, all of the blood is going to leave to the aorta, so the volume is going to decrease. And then you have dilation or diastole, but again in a form of closed chamber. That is, the volume won't change, but the pressure would drop down. So it's your entire PV loop, right? Isovolumetric contraction, then your systolic ejection, then your isovolumetric relaxation, and rapid filling. We know the three phases: rapid passive filling, then your atria and then contracting and everything. You guys know that, okay? Hello?
Okay.
Okay, so let's discuss our heart sounds. So you guys are going to be telling me S1, S2, S3, and S4 in detail. We spent a lot of time, Dr. Moss spent a lot of time on these, and I as well spend a lot of time. So I'm expecting you guys to be telling me that. S1, S2, S3, and S4. Okay, so let
As
me
when
just.
closure of
Okay.
mitral and
Dr.
tricuspid
Jamil is
valve.
going to be Dr. Jamil is going to be telling us about S1 and S2.
Yes, S1 is produced when closure of the mitral and tricuspid valve. S2 is produced closure of the aortic and pulmonary valve.
Where
And
do we auscultate both of these sound?
okay, mitral we can hear it in the left sided of the heart, mid clavicular line, apex of the heart.
Apex, perfect.
Yes, and the tricuspid we can listen lower sternal border, left sided
Right
of
side or left side? Left
left
sided.
sided, left
Which
lower sternal
intercostal?
border, and third and
Which
fourth filter.
intercostal space?
Yes.
Third
Yes.
intercostal, right? Perfect.
Yeah.
What about S2?
S2 produce the closure of aortic and pulmonary valve.
Where are you going to auscultate the aortic valve closure sound?
Aortic valve is the right-sided second intercostal.
Perfect. Where do we have pulmonic area?
Pulmonary area, the left-sided second intercostal space.
Perfect. Okay. So Dr. Nafia. Dr. Nafia, can you just please turn on your mic?
Yes.
Can you just please tell us the three phases of your ventricular filling
Okay.
or
So
diastole?
so ventricular filling has an early diastolic filling, at which we heard the S3 heart sound in the left lateral decibel position.
Okay, I was asking the three. Okay, let's be more specific. You have diastole, first of all, metal valve is going to open. All of the blood is going to enter. That is rapid passive filling. Then what's the
Yes.
second?
Then there is a slow filling of the heart during the diastolic phase, in which we
Okay,
heard that
so think where is the blood coming from?
from the left atrium into the right ventricle.
From the left atrium, or specifically, can I say it's directly coming from the pulmonary veins?
Yes.
Pulmonary veins.
Perfect. In the third phase,
In
you're forcing the blood to enter into your left ventricle. So that is your atrial contraction, atrial kick.
Yes.
Okay. So when is S3 heart sound produced and why?
So S3 heart sound produced during the rapid ventricular filling phase because the ventricles
And
are
why?
because the ventricles are emptying and there is the sudden start filling of the ventricles.
So do we hear? Okay, so you mean to say that in every individual in the rapid passive filling, we are going to hear S3?
Volume.
S3
Let's raise it. It shows the
Yes.
volume
Let
overload.
her speak, guys.
Hello, there is a lot of disturbance. Please fix that. Dr. Zalwa. Hello. Okay.
Let Dr.
Whenever we have volume overload states, that is mitral regurgitation, aortic regurgitation, heart failure, thyrotoxicosis, we have eccentric hypertrophy, a large surface area of blood. So in those individuals, in the rapid passive filling, blood is actually going to come. It's going to splash the surface of the big surface area which is already present there. And in that case, we're going to hear S3 heart sound. My next question for you is,
But it
how
is
do you?
common in young athletes and pregnant women and the
Yes,
children.
why?
Yes.
Because volume overload in these kind of individuals is normal. Because we know that in endurance training athletes, the eccentric hypertrophy is normal. We know in pregnant ladies, increased blood volume is normal because you need to, perfuse the fetus as well, right?
Yes.
And young adults, that's normal. Okay. So my next question for you is, for example, if I want to auscultate S3 heart sound, what would be the position of heart and at which phase of your respiratory cycle I'm better going to hear S3? That's your word answer.
So the S3 heart sound it can be heard at the apex, in the left lateral. We place the patient in the left lateral decibel position, and we ask the patient to inspire so that the venous return inspire, so that the vein.
It's heard in the expiratory phase.
And expiration phase. And expiration. Why? Because at that time, these are very small, less intensity sound, also known as gallop sounds, right? So we are going to auscultate it at end expiration. Why? Because at that time your heart is close to your chest wall. So even the small sounds can be heard quite great, but not normal. Are we going to as auscultate it with the bell of stethoscope or with the diaphragm?
Bell.
Bella.
Bell of stethoscope. This is also one of your viewer density because these are slow intensity sounds. What about S4 heart sound?
So as for heart sound, first of all, it's in the late diastolic filling phase, and it's common only in like in older people because of the age relating things to the old people, and also it's seen in the hypertensive patients and in the hookah.
Why?
Because of the concentric hypertrophy, the heart got so stiff
That's
with the all the muscle.
basically atrial kicking against stiffened wall. And in all of those conditions, the wall gets stiffened, concentric hypertrophy, right?
Yes.
Perfect. So that was all about your heart sounds. So let's move to JVP. So Dr. Moaz explained JVP in a big detail. You know, so I'm expecting you guys to be telling me. I'll be only drawing the graph, and you guys have to tell me different events, right? Okay. So you have your A wave, your C wave, your X descent, your V wave, and your Y descent. A wave, C wave, X descent, V, and Y descent. What is your A wave?
Atrial contraction.
Atrial contraction.
If the atria contract, pressure is going to be increasing the veins because they do not have connection. Do you guys remember the example which I gave you, the ball placed in the
Yes.
Yes.
Yeah.
Okay. Then you have your C wave. When is C wave produced?
When there is the contraction of right ventricle.
And as the right ventricle contracts, it would just push
Contraction
the
of
tricuspid
tricuspid
valve.
valve.
Yes, it would just push the tricuspid valve back into the left atrium. Pressure is going to increase. The right atrium pressure is going to increase here. Then we have X descent.
Now the right atrium will relax. So there will be decreased pressure in right atrium. That's why JV pressure will decrease.
And
Perfect.
downward placement of the tricuspid.
Perfect. Downward placement of the tricuspid, relaxation of the right. So you're going to have drop in pressure, that is X wave. What about V wave?
Again,
Now
when
again the pressure will
Filling of volume. Filling of the
Perfect.
atrium.
Now your atria is relaxed, it will just accept a lot of blood. That is V wave, right? More pressure. What about Y descent?
The right ventricular atrium filling plus passive filling of the right ventricle.
Perfect. Right atrium directly, draining all of the blood into your right ventricle. That is right atrial empty, right? So these were all of your JVP. Is that clear? What happens to the, okay, which wave is going to be absent in atrial fibrillation? And why?
A wave.
P
A
wave.
wave will disappear. A.
Because there is ineffective contraction of the left atrium. That's
Atria
why.
do not contract, so the A wave is going to be absent. What happens in tricuspid regurgitation?
X wave should disappear.
Why?
Because they don't.
V wave will be behind in tricuspid regurgitation.
No closure.
I think X wave.
Because
Okay, that's
C.
absent X descent, right? So the X descent
Yes.
was basically produced whenever we have atrial relaxation. But in regurgitation, as the blood is entering back into your atria, so there is a proper relaxation time. So what happens? The pressure is going to increase instead of decrease, right?
Yes.
What happens in constrictive pericarditis?
The Y descent.
Why?
Because of the right atrium emptying into the right ventricle. So it's going to be prominent, but it's going to be absent in the cases of tamponates, cardiac tamponates.
Perfect. So in constrictive pericarditis, as we have collected, the heart is constricted towards filling. Keep that in mind, right? So it happens that the Y wave is going to be more prominent, right? That is right atrial emptying into the right ventricle. It's going to be more prominent. We have constrictive, and in cardiac tamponade, Y is going to be absent. Just keep that in mind, okay? We'll be discussing the details of these waves in the respective pathologies as well. So for now, let's, just only memorize it. So the next topic which we are going to discuss, okay, so let's have 5 minutes of breakfast. So we already, have 1 hour of lecture. So let's have 5 minutes of break, and then we'll be continuing our discussion on aortic stenosis, regurgitation, astral splitting. Okay.
I have a question.
Okay.
Yes, please.
So in constrictive pericarditis, they didn't show the C wave. So why is that?
Okay, we are going to discuss that in constrictive pericarditis. Okay. So for now, once you know the constrictive pericarditis, then we are going to discuss that.
Okay.
Hello? Hello?
Yes, doctor.
Okay, perfect. So let's start our next topic that is going to be different pathologies, and I'll be asking you questions. You guys have to answer me that. But before answering, you guys have to raise your hands. Okay, that's really important. Or I'll be just picking the students who are going to participate. Okay, so let's start with Dr. Adonia, right? Dr. Adonia, can you? I'll be just asking you some questions. You have to answer me. So the first pathology which we are going to discuss is aortic stenosis, right? So for example, if aorta gets stenosed, what would happen to left ventricular pressure? Dr. Adonia?
It will increase
Perfect.
left
What would
ventricular
happen to,
pressure.
perfect. What happens to the end systolic volume?
He finished 12 pages.
The end systolic volume would increase.
Our question discuss ചെയ്യാൻ വിളിച്ചു ബാക്കി ഞാൻ പറഞ്ഞു ഞാൻ ക്ലാസ്സിൽ ഇരിക്കുക
Dr. Fatma, can you please fix your mic? Hello? Okay. So, can you just tell me that if we have aortic stenosis, would there be some adaptation in the left ventricle?
Yeah, so because of the stenosis and the increased pressure, the left ventricle will hypertrophy.
Okay, why? Because the afterload increases, right? And whenever we have increased afterload, it's going to lead to hypertrophy. Perfect. So the next thing which we are going to discuss is aortic regurgitation. In aortic regurgitation, what happens to end diastolic volume? We already discussed that.
The end diastolic volume would increase.
As the end diastolic volume increases, what does the Frank-Starling mechanism tell us about that? It means preload increases. So what will happen to stroke volume?
Anytime the preload increases, the stroke volume will increase.
Perfect. Then we have mitral stenosis. If in the mitral stenosis, what happens to left atrial pressure?
The left atrial pressure will increase in order to open the mitral valve. Because the mitral valve stenosis, so it will have you need more pressure to get the blood through.
Perfect. What will happen to end diastolic volume if we have closed mitral valve, stenosed mitral valve?
The end diastolic volume will decrease because since the valve is stenosed, it will be harder to get the blood out since the pressure is increased.
Perfect. So if you have less blood now in the ventricle, that is the end diastolic volume is decreased. What does the Frank-Starling mechanism tell you?
So for that, the stroke volume is gonna decrease.
Perfect. That's perfect. In case of mitral, okay, let me ask you a question. We have an individual with mitral regurgitation. What happens to the afterload of your heart? Increase or decrease?
The afterload would decrease in regurgitation.
Why?
Let me see. The afterload will decrease because mitral regurgitation. Because
yes, now you have for the blood to flow. Now the blood will, some of the blood will flow into the aorta, some of the blood will flow back into the left atrium. So you have two pathways. If you have two pathways, the resistance decreases, right?
Yeah. Yes, that's true.
Perfect. And as in case of mitral regurgitation, in the second phase of the atrial contraction, you will be having more blood in the left ventricle. That is, end diastolic volume will rise.
Yep. The end diastolic volume will increase, and the stroke volume will also increase because you have blood going into the like two sets of blood going out.
Perfect. So can I say that there will be a kind of volume overload state?
Yes.
So would there be any heart sound related to volume overload state, that is S3?
Yes, you can have S3 in mitral regurgitation.
Perfect. That's perfect. So let's discuss our next topic. That is, are you guys getting? It's a kind of revision. You guys already know that, right? You have to pay attention towards that.
Yes.
Next topic which we are going to discuss is S2 heart sound. So in the S2 heart sound, we are going to discuss like the 2-1, right? So the paradoxical splitting, it's your homework. You guys have to read that, okay? So we'll be more focused on physiological splitting. What is physiological splitting and how do we have that? Yes, what is splitting of S2? Dr. Abdul Rauf.
Yes, sir. So the physiologic splitting is basically that when we are inspiring, so the thoracic cavity pressure is decreasing. So when the thoracic cavity pressure decreases, so the venous return toward the heart increases, and more blood is reaching the right ventricles. So there, that's why the right. Yes, sir.
I'm asking, the right ventricular preload increases during expiration or inspiration?
Inspiration, because inspiration decreases the thoracic cavity pressure. So
Yes.
venous return increases. So the right ventricles now have more blood. So as now they have more blood, so they will have, like, they will take more time to take that blood out. Their ejection time would increase.
Perfect. So
So
closure
that's
of valve is going to be delayed. P2
yeah, the
component.
closure of the pulmonic valve will be delayed. So because of that, we will see this physiologic splitting.
Perfect. So we know that S2 basically comprises of two components, closure of your aortic and closure of your pulmonic. So during inspiration, whenever the right-sided preload increase, it will just take more time for the pulmonic valve to close. So first of all, we are going to hear A2 component, and then we are going to hear P2 component. So we are going to have splitting of that S2 sound, right? So that's physiological splitting. Can you just tell me what is fixed split?
The
You
fixed
already-
splits are we see in the atrial septal defect. Because there is a shunting taking place, so there will be like more increased level of blood in the right atrium and the right ventricle. So
Perfect.
when they have more blood, so like more blood is flowing away from, like more blood is flowing through the pulmonic valve. So again, it is closing late. Its
Will
closure
it
is
be any murmur associated with this? With ASD?
Systolic ejection
Systolic one.
Systolic ejection.
The left lost.
in left upper sternal border.
Perfect. So we are going to have an ejection murmur there because more blood is now going to move through that pulmonic wall, right? So that's why we are going to have an ejection murmur there as well. Okay, perfect. Then we have wide splitting. What do you mean by wide splitting?
So wide splitting is like in all condition, like the right ventricle will get emptied slowly. So because of that, we will hear the wide splitting.
And which condition do we have slow
Pulmonic
emptying?
stenosis,
Pulmonary stenosis and right bundle branch block.
Perfect. Okay, so this was all about your splitting, paradoxical splitting. It's your homework, right? You have to read it. Okay, so then we have different menus, right? So for the menus, we won't go into the details. What your first aid is telling you, you have to read it, but I'm going to give you the concept. You already know the concept. If we are performing a Valsalva maneuver, we have two phases. Can you guys just tell me those phases?
We have strain and we have release phase.
Perfect. So in the strain phase, what happens to right-sided preload? Increase, decrease.
It should decrease because the thoracic pressure increases.
Perfect. Thoracic pressure increases. So in the strain phase, as we are applying more pressure to the thorax, as a result of that, what happens? Preload would decrease, right? What happens in the release phase?
It should increase because now the pressure will be decreased, so the volume will increase.
Perfect.
The right side, and then
Okay. We have leg raise maneuver. If you are raising the leg, it means we are directing all of the blood towards your heart. So what happens to the preload?
it should increase.
Increases.
Increase. Perfect. Then we have a squatting maneuver. In squatting maneuver, what happens to the afterloading or preload?
Afterload will increase because when we squat, the small arteries they get vasoconstrict, and moreover, preload will be increased as well because
Perfect.
the
Because
weight.
you are directed
Constriction of the
heart via venous constriction. Then we have hand grip maneuver. If I'm hand gripping, what happens to the afterload?
It increases due to increased peripheral vascular resistance.
Yeah. Okay. We have an individual, he's having hypertrophic obstructive cardiomyopathy, right? He undergo hand grip maneuver. What happened to intensity of murmur? Increase or decrease, and why?
Decreases.
Increases.
It should decrease.
Decreases
Decreases
due
due
to
to
increase of
increased left
afterload.
volume.
Decreases because there will be
No, not afterload. Preload.
Please, one by
pressure is critical.
please, one by one. Dr. Jamil.
So in hypertrophic cardiomyopathy, the hand grip will decrease the murmur because you have more volume going through.
No, because there is high pressure in the aorta. and pressure gradient decreases, that's why there will be decreased.
Utama, please could you put
In hand grip,
more light
decrease
on
the
this?
afterload, not the volume.
Why?
Afterload decreases, and that's why decrease the in aortic stenosis and HOCM. The murmur decreases with increase of the afterload.
Got it. Thanks.
Mitral valve. Oh no.
Hello? Hello? Hello?
Yeah.
Okay,
Yes.
so I had a call. Okay, so we were discussing about hand grip maneuver, right? So we have an individual, he's having hypertrophic obstructive cardiomyopathy. What would happen to the intensity of murmur with hand grip maneuver? Increase or decrease?
Decrease.
Why?
Because there will be high pressure in aorta, and the pressure between left ventricle and aorta gradient will be decreased, so the intensity will decrease.
Perfect. So actually the murmur is due to functional stenosis of your aorta. Which structure causes this stenosis? Some parts of your interventricular septum and your tricuspid valve cusps, right? So if you're increasing the afterload, it means that more blood is going to stay in your left ventricle. If more blood is staying in your left ventricle, so both of these structures are going to be apart from one another. So the functional stenosis is going to be decreased, and as the functional stenosis decreases, the intensity of murmur also decreases. Is that clear? Hello?
Yes.
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 Okay, so someone was asking me a question. Any questions? Hello? Okay, shall I move to the next topic? Okay.
Yes, sir.
Okay, perfect. So now let's discuss heart murmurs, right? So you guys already know about heart murmurs. Again, it's going to be a more of question and answer session. The first one is aortic stenosis. So I want you guys, whenever we have a murmur that is radiating towards carotids, so what should be the first thing in your mind?
Aortic
It's
stenosis.
aortic stenosis. Perfect. We have an individual. He's having bicuspid aortic valve. So the probability of getting aortic stenosis is increased or decreased?
Increased.
Increased.
Increased. Even like he's going to get aortic stenosis like at 50 years of his age. So whenever we have aortic stenosis, what happens to the afterload?
Increases.
Increases. Perfect. So, and the most common cause of aortic stenosis is an elderly individual.
Calcification.
Calcification. Perfect. So if we have stenosis aorta, so won't it be difficult for the blood to get into brain?
Yes.
Okay, if we have stenosis aorta, we have more afterload. What would happen to the oxygen demand, as we already discussed, of your heart? Increase or decrease?
Afterload.
If the oxygen demand increases, and let's suppose an individual already is having some coronary artery disease, won't it cause angina or ischemic pain?
Yes.
Perfect. Won't it cause dyspnea if you have aortic stenosis due to backup of blood in the left ventricle, in the left atrium, into the pulmonary? Perfect. What are heart failure cells?
Heart failure? It should be S3.
What do we mean by heart failure cells?
Heart failure cells are in
One by one, please. One by one. Okay, so what happens in heart failure cells that whenever we have backing up of the blood within the lungs, so what happens? Your macrophages, like your red blood cells, can leak through the vasculature. Macrophages are going to eat that. It's going to give you a brownish kind of hemosiderin-laden macrophages, which are also known as heart failure cells. What cells or what characteristic features are similar on histopathology as that of heart failure cells? A little bit brownish, but it is an outcome of increasing age.
Lipofusion.
Lipofusion. Perfect. So these were all of the MCQs which we are going to test you. Okay. So let's discuss our next topic, that is mitral or tricuspid regurgitation. Right. So as okay, where are we going? Okay, what is going to be the murmur present in case of mitral regurgitation?
High pitch hollow systolic.
Okay, hollow systolic murmur. Perfect. Where at which area are we going to auscultate it best? The loudest at its loudest at
Apex. For mitral apex.
apex. Perfect. Okay. So if we have mitral regurgitation, so in which condition do we have mitral regurgitation? Okay. So for example, if an individual is having rheumatic fever and in an acute phases of rheumatic fever, is he going to have regurgitation or stenosis of mitral?
Acute. Acute.
Regurgitation.
Regurgitation. In case of chronic phases, it's going to
Stenosis.
Stenosis. Perfect. Keep that in mind. We have an individual, he's having Marfan syndrome, right?
Yes.
What is Marfan syndrome, first of all?
There is a mutation in the fibrillin protein, which further
Okay.
leads to the disruption of the cementing particles.
Okay, perfect. So if we have disruption of fibrillin, so we are going to have two outcomes of that. First of all, you know the aorta, there is going to be cystic medial degeneration, if you guys remember. It can lead to aneurysms, it can lead to dissections, and along with that, it can also impact your chorda tendini. So what are chorda tendini?
These are the structures which keep the this how's it called mitral. I mean this valve. Keep
There are strings attached to the valve.
fix it. Yes.
There are strings.
Perfect. So
It helps
whenever
to keep position. Yeah.
okay, okay. So I'll be select. Okay, Dr. Kems. Dr. Kems, can you please turn on your mic? Hello. Dr.
Yes,
Rehana, can you please fix your mic? There's some noise. Okay, Dr. Kems, my question for you is that in mitral valve prolapse, for example, an individual having Marfan syndrome, he's having mitral valve prolapse. So we are going to hear a characteristic murmur kind of sound. What would be that, and why is that produced?
It mid-systolic murmur.
Perfect.
Mm-hmm.
And what's going to be the characteristic, feature of that? Click. It would be a click, right? Mid-systolic click.
Yeah.
And when is that click produced? Whenever we have sudden tensing of that weakened chorda tendini. Okay, that's going to be one of your U-word question as well. Is that clear? Like, let me just draw it here. Okay, just give me a second. Can you guys just see my screen?
Yes.
Hello?
Yes.
Okay, perfect. So for example, if this is your heart, you have your tricuspid valves, you have your chorda tendini attached to papillary muscles. So what happens in Marfan syndrome is that you have degeneration of chorda tendini as well. It would just become a little bit, loose, right? So during contraction, what happens? This valve is going to prolapse back into your left atrium, and as a result of that, it's going to cause sudden tensing of that weak area of your chorda tendini, and it's going to produce clicks. That is sudden tensing. Okay. Hello.
Yes.
Yes.
Okay, perfect. Perfect. So the next one is ventricular septal defect. We already discussed about ventricular septal defect, hollow systolic murmur, large intensity with
Sorry, Dr.
smaller.
Ahmed.
Yes, please.
I want you to give the difference between mitral valve prolapse and mitral valve regurgitation.
Okay. So in case of mitral prolapse, we are gonna see mitral valve regurgitation of blood as well, right? So in prolapse, as we discussed, we have loose chorda tendina. The chorda tendina normally keeps this valve at this mitral valve cusp at place. But if it gets loose, right? So with every contraction, want to think that this cusp is going to move back into left atrium with every contraction? Hello?
Yes.
Yes.
Sure.
So it would be like whenever the chorda tendina become loosened, so what happens with every contraction, your mitral valve cusp is going to prolapse back into left atrium. So that's mitral valve prolapse, right? Prolapsing back into left atrium, mitral valve prolapse. And with that, the valve is going to be incompetent, obviously, so some blood is also going to move back into left atrium. It can lead to regurgitation.
Regurgitation as well. Okay.
Is that clear?
Okay.
Okay. So the next topic which we are going to discuss is aortic regurgitation, right? Okay. So for the aortic regurgitation, who is going to be telling me the murmur associated with aortic regurgitation?
So like it's a diastolic murmur. This will be a high-pitched blowing diastolic murmur.
Okay, perfect. So it's going to be a
Diastolic
diastolic.
decrescendo murmur. Yeah.
Okay, so it's going to be a diastolic decrescendo murmur. As the blood is leaking back into your left ventricle, so it's going to be decrescendo, okay, blowing, a high-pitched blowing murmur. So when do we get aortic regurgitation? The idea is really simple. For example, if the aortic wall isn't closing well, what happens? All of the blood is going to get back into your left ventricle. And how do the aortic wall do not close as well? That is, whenever we have aortic root dilation. Right? Hello?
Yes.
What
Yes.
else? What else can lead to aortic regurgitation?
Bicuspid aortic valve, BEAR, beer. Yes, bicuspid aortic valve. Endocarditis, rheumatic fever.
Aortic root dilation.
Okay, perfect. So that is endocarditis as well, right? So if you have endocarditis here, if you have vegetation sitting, so in every kind of endocarditis we discuss, we will be having vegetation, and it would be difficult for the valve to close. If the valve isn't closing well during diastole, so the blood is going to come back. That is regurgitation, right? Bicuspid aortic valve can do that as well due to not proper closure of your valve. Is that clear? That's going to lead to aortic. What will happen to the pulse pressure as we already discussed?
Increase.
Increase. Perfect. So the next topic is mitral stenosis. We have already discussed each and everything in detail, but it's a kind of revision for you guys. Which murmur is associated with mitral stenosis?
Rumbling murmur.
Opening snow. Diastolic rumble.
Will be a
Is an open snap.
mid-diastolic rumble.
Okay, so it's going to be a mid to late murmur that is, followed by an opening snap. Like as the pressure is building within the left atrium, so suddenly the valve is going to open, which is going to give you an opening snap. It's same as that of if we are opening a soda bottle, right? You have a lot of pressure. If I'm removing the cork, so what would happen? It would just give me a sound that is, opening snap. Okay. So, in which condition do we have mitral stenosis? We already discussed one of the conditions in the chronic phases of rheumatic fever. We can have mitral stenosis, remember? And if you are having mitral stenosis, we know that the left atrium is going to become dilated, causes Ortner syndrome, dysphagia, and everything. You already know that, okay? Hello?
Yeah.
Okay,
Yes.
perfect. So these are all of the concepts from physiology you should just keep in mind, okay? So you're going to see this repeating again and again, and it's a kind of revision for you guys. Then patent ductus arteriosus. What's the characteristic murmur? You guys have to tell me that.
Continuous
Machine murmur.
Continuously.
Both during systole and diastole continuous murmur, that is machinery-like murmur, machine-like murmur, okay? So this was all about your murmurs, and I think you guys already have done your lectures with Dr. Moaz, with Dr. Mahin. You did your U World, and now I'm revising these things. So I think everything is making sense. Okay. So now we have only 2 to 3 topics remaining in physiology, and for that I have to draw a graph, and Dr. Jamil is going to be telling me that. Okay. So this is a graph of your nodal cells or myocyte, cardiac myocyte.
Myocyte.
Yes, this is my side.
So it's phase 0. Phase 0 is basically due to influx of which ion?
Sodium.
Sodium.
Phase 1.
Phase 1, this very short is
Potassium
efflux of the potassium.
Efflux of your K+. Phase
Yes.
2.
Phase 2 is plateau phase, is influx of calcium.
Only influx of calcium?
And gradually the potassium also going out.
Okay, Dr. Jamil, please. Only Dr. Jamil should answer me, okay? So you have influx of calcium while efflux of K+, so that's why we are going to have a
Plateau phase.
Then we have phase 3.
Yes, this efflux of potassium.
K+ efflux. Perfect. So we have class 3 antiarrhythmics. It's going to give us,
yes. It's working on stage 3.
It's going to lead to formation of which kind of tachycardia?
It's
polymorphic.
polymorphic PT or what this is the point.
Let's make it simple. Prolongation of QT interval, right?
QT interval, yes.
Torsion.
So
Torsity
torsion.
point can cause.
Perfect. That's simple, right? So you should just keep things as simple as you can. And I just told you the ECG time with this graph, if you guys remember, right? The
Yes.
QT interval shows both of your depolarization of your ventricle as well as repolarization, which is indicating your entire action potential, right? QT is for your action potential,
Yes.
right? And as we are delaying this, so the QT or the action potential duration get prolonged. Is that clear?
Yes.
Okay, perfect. Then we have pacemaker action potential. So first of all, I want you to tell me that the zero phase is due to influx of which ions? Really important.
Calcium ions.
Calcium ions. What about your phase 3?
And this potassium out.
Potassium moving out. Perfect.
Yes.
So you should just keep in mind the calcium influx or the depolarization is basically carried out by the influx of calcium. That's really important. You have a lot of MCQs on that. Then you have, you know, the SA node, the AV node, their location. So where is SA node located?
SA node is opening of the superior vena cava.
Okay, where is, do you have AV node?
AV, it's near to tricuspid valve in the right atrium, near the septum of the, what you say, this
Atrial septum, right?
atrial septum, yes.
Okay, perfect. So this was all about the cardiac potentials. You have some of the things you can just read it, although they aren't high yet. If you know the graph which I have drawn, that's more than enough, right? So ECG, really important. And I have just, if you remember, I spent a lot of time on ECG. So I'm hoping that you guys should know a lot of it, right? What is this?
P wave is contraction
What
of
does it
the
indicates?
electrical contraction of the atrium.
Atrial contraction. What is this interval?
This PQ.
PQ interval?
PR.
PR, sorry, PR.
PR.
PQR, yes. This due to the AV node pause.
AV nodal delay, right?
Yes.
Okay, this is your QRS complex, right?
Yes, QR complex contraction of the ventricle.
Contraction of your ventricle. And what about T wave?
T wave is repolarization of the ventricle.
Repolarization of your ventricle. Perfect.
Ventricles.
So of your ventricles. Perfect. So you should just keep that in mind. The normal PR interval is around about 120, something like that. Okay. Okay. So the QRS is like less than 100 milliseconds. QT interval, you guys know it's the entire action potential. The QT interval, whenever we have prolongation of QT
Less
interval.
than 400, yes.
Perfect, less than 400. So it was all about your ECG. We already discussed that in detail. Okay. So next topic. Okay, so we only have 2 topics remaining, 2 to 3 topics remaining in the physiology. So the next topic is, you know, ANP and BNP. So I want you guys to be telling me as fast as you can. ANP and BNP. Okay, let me just pick someone for this discussion. Okay, so Dr. M.O. Dr. Mo, can you please turn on mic? Dr. M.
Oh, yes, sir.
Perfect. So can you just tell me about ANP and BNP? From where do we get ANP? From where do we get BNP? What are the function? What are the stimulus which lead to, you know, like release of ANP? From where do we have release of ANP and BNP? And what are the function of them?
Hello.
Okay,
So the ANP is
what does ANP stand for?
the atrial natriuretic peptide.
Atrial
So these are
natriuretic.
released from the these are released from the atrial myocytes.
Whenever
And
they
BMP is
contract
released
or
from
whenever they stretch, right?
yes, they are stretched. Yes.
Perfect. How do we have BNP released and from where?
The BNP are released from ventricular monocytes when they are stretched again.
Stretch again. Perfect. So both ANP and BNP, natriuretic peptide, it means it's what are they going to do to the concentration of your Na or sodium?
They help in pushing out the concentration of sodium. They
Decrease
have
Na.
a decrease.
Perfect.
Yeah.
Can I say that
Along with,
if they are decreasing Na, so they are opposite to your RAS system?
yes.
Perfect. So we have an enzyme which degrades ANP and BNP. What's the name of that enzyme?
Neprolysin.
Realizing.
Okay, and we have a drug which inhibits this enzyme. What's the name of that drug?
Sacubitril.
Perfect. So this is one of your keyword MCQ you guys should know that. So next topic is really important, really high yield, and I want you. Okay, I'll be asking you some questions, right? So you guys are going to give me a better explanation of that, and I think we have to spend some time on this topic as well. So Dr. Felix, can you just please turn on your mic? Hello.
Dr. Ahmed, there is one small information about BNP, if you allow me. BNP is brain attributed because of the scientists before they were thinking it was secreted by from the brain. That's why its
Yeah.
name is BNP.
So actually, yes, the history is
Yeah,
really,
and the second is we do the BNP test because of the ANP very short half life, and BNP is the long half life. That's why we in the lab check only BNP.
perfect,
Just
right?
just
So
little
it's
information.
basically known as, like as Dr. Jamil told us, really good information. So it's basically known as brain, right? So basically, it was first of all discovered in the brain of frog, right? Frogs, in the frog's brain. So that's why it was first initially known as brain natriuretic peptide. But after that, they came to know that it's released by your ventricle as well, right? So BNP, brain natriuretic. That's why it's known as brain natriuretic peptide. Okay. So yes, my question for Dr. Felix. Dr. Felix, can you please turn on your mic? Hello? Hello? Dr. Abida. Dr. Abida, are you here? Hello? Dr. Al Sahar. Hello? Can you guys hear me? Hello?
Yes. Yes, we can hear
Yes,
you.
yes.
Okay, Dr. Aksa.
Yes.
Okay, so my question for you is, we have an individual, he's having COPD, right?
Yes.
Hello? We have an individual, he's having chronic obstructive pulmonary disease. What happens in chronic obstructive pulmonary disease? What happens to oxygen concentration or oxygen saturation in case of chronic obstructive pulmonary disease?
It's
My first
reduced.
question. It decreases? Hello? Yes, guys, please wake up. Hello?
Yes, we can
Yes,
hear you.
decreases.
It
Decreases.
decreases.
Okay. So Dr. Aksa want to tell us that during COPD, oxygen concentration decreases. Dr. Prisca, Prisca. Hello? Are you here? Can you please turn on your mic?
Yes,
Okay.
I'm here.
So my question for you is, if you have an individual who is having COPD, why would I avoid giving him 100% oxygen? We
Because
won't
that
give him.
will 100% oxygen will suppress their chemoreceptors that are usually detecting low oxygen suppression, which is normally their driver for breathing.
Okay, so what would happen to an individual if you give him 100% oxygen?
You suppress that drive.
Okay, if you
chemo-
suppress, so would there be like, what would happen to the carbon dioxide level if you are suppressing it?
They will further increase. So
Increase,
they'll,
perfect.
yeah, so they'll get hypercapnia and eventually respiratory acidosis.
Okay, perfect. Can anyone just give me a better explanation? That was quite a good explanation, but can anyone else elaborate it?
Yes, Dr. Ahmed, can I? Yes.
Yes, Dr. Jamil, please.
Yes, in COPD in patient, most of them we have two center for the respiratory. One's peripheral, one the center respiratory center. It's in medulla, and in what it is stimulated by the carbon dioxide. In COPD patient, there is chronic hypercapnia, and this center is already adapted. It will not respond to the higher capnia. Hypercapnia means, and the peripheral it's the carotid bodies uh, in the carotid arteries. It responds to hypoxia when there is low PO2 less than 60. in COPD patient, they are hypoxic, and their respiratory drive is due to peripheral stimulus due to hypoxia. If we give the 100% oxygen, and it will definitely will diminish the response of the oxygen, and the centers, they will think that okay, already there is an oxygen, they will stop the stimulus from the peripheral, from the carotid bodies. Then patient yes get the worst conditions.
Perfect. Do anyone have any questions in this topic?
No.
No.
Okay, perfect. So the idea, okay, let me just give you a small overview, those who didn't get it. So let me just make it very simple for you guys, just go through. So basically we have two kind of receptor, that is peripheral chemoreceptor and
Central.
central chemoreceptor. Central chemoreceptor are only responsive to carbon dioxide. Whenever we have increased carbon dioxide, what the central chemoreceptor are going to do, they are going to stimulate your respiratory centers in your medulla, right? And as a result of that, an individual is going to undergo hyperventilation, and in this way, he is going to eliminate all of the carbon dioxide. But the peripheral is responsive both to increase your carbon dioxide but decrease oxygen as well. So if you have an individual with COPD, what happens? We have chronic hypoxia, a lot of carbon dioxide for a longer period of time. So your central chemoreceptor becomes sensitized to that. It won't respond, right? So now only this individual is depending on he is dependent on the peripheral chemoreceptor. So if now we are giving this individual 100% oxygen, what happens? Now we are, okay, so decreased stimulation leads to stimulation of your respiratory centers. If I'm increasing, so it would decrease the respiratory center stimulation. As a result of that, we'll be having hypoventilation.
Doctor,
Is that clear?
can you say one more time, please?
Okay, so we
There's
have central
actually a
chemoreceptor.
disturbance. Somebody's mic is on.
Can you guys please just fix your mic, because like I don't want to mute all of you. So those who are having some disturbance in their mics, please fix that by your own, please. It's a humble request. Okay, so first of all, you should know that we have two kind of receptor: your peripheral receptors and your central receptors. Whenever the peripheral receptors are stimulated, it is going to further stimulate your respiratory center, right? And what the respiratory center stimulated is going to lead to hyperventilation. Whenever the peripheral center is least stimulated, it would everything is going to be opposite. It's going to inhibit the respiratory center, and we're going to have hypoventilation. Is that clear?
Yes.
Yeah.
Okay. So how do we stimulate peripheral receptors? Whenever we have increased carbon dioxide or decreased oxygen. Okay, and same is the story with central chemoreceptor. So central chemoreceptor only respond to CO2. Whenever we have increased CO2, it's going to stimulate your respiratory center. Again, it's going to lead to hyperventilation. And the opposite, whenever we have less carbon dioxide, it's going to decrease stimulation of respiratory center. This is going to lead to hyperventilation. Is that clear? It's a normal process. Is that clear?
Yes.
Okay. So during COPD, as we have chronic elevation of carbon dioxide, so your central chemoreceptor won't, it would stop responding to increased carbon dioxide. Now only this individual is going to be dependent on decrease in oxygen concentration, right? So whenever the oxygen is getting less, in that case, this individual is going to stimulate his respiratory center and lead to hyperventilation, right? So an individual with COPD, he's solely dependent on decreased oxygen. So if now we are giving 100% oxygen to this individual, it means that we are inhibiting the peripheral receptors, right? Hello?
Yes.
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 If less oxygen stimulate it, so more oxygen would inhibit it, right? It would inhibit your respiratory centers. It would lead to hypoventilation. Hypoventilation lead to more carbon dioxide retention. So you are worsening the patient condition further by increasing the carbon dioxide level. Does that make sense?
Yes.
Okay, perfect. So next topic is baroreceptor. So in the baroreceptor, I'll be asking you some questions. You guys have to tell me that, okay? Okay. We have an individual, we are doing carotid massaging for him. It would lead to syncope. How and why?
Doctor, because when we are doing this massage, okay, it means
Mhm.
the impulse will go to the brain, okay? So the parasympathetic will be activated, right?
Perfect.
So when this parasympathetic will activate, it will act on the heart. Yes, it will decrease the cardiac output. When the cardiac output will be decreased, it means the low blood will go to the brain. Hence, it can lead to syncope.
Perfect. So as we are doing carotid massage, basically you are tricking your brain, right? Like carotid massaging means like your brain will be tricked. It would be thinking of whether we have more pressure there. We have more pressure. So whenever we have more pressure, your brain respond in a way of parasympathetic response, right? So in order to decrease your blood pressure, it's going to initiate a parasympathetic response. So in this way, we are tricking our brain. So we have a condition. Let me just give you another scenario. We have a condition, an individual, he was shaving, right? He was just shaving, and suddenly he become, disorganized, syncope, he fell down. What do you think is the pathology here?
Yes,
The
he has to
same.
suppress the baroreceptor in the neck, and it's decrease the stimulus and the same pathway in the
Okay,
parasympathetic
so the
activation.
pathology here is like hypersensitive baroreceptors, right?
Yes.
Because normally during shaving, it won't happen. If you are just, tucking your collar, if you're just shaving, normally it won't happen. But if an individual is having a syndrome or a pathology that is known as carotid hypersensitivity syndrome, right? Hello?
Yes. Carotid
Yes.
So in those
hypersensitivity.
cases, even little stimulus
During
of your carotid.
when they fix the tie or they close the button of the collar also.
Yes, so I'm just talking about that if you are talking the collar as well, right? So what happens due to carotid hypersensitivity syndrome is now your receptors are very sensitive to like least touch. So even touching your collar or even shaving is going to stimulate your baroreceptors. And as a result of that, it's going to initiate a parasympathetic response. It would lead to syncope. That's all. Okay. So with this, we have finished our physiology. So we have two small topics remaining: pressures within different chambers of your heart, right? You should just do that by your own. And capillary fluid exchange. That's your topic, your task. Is that clear? So let's have 10 minutes of break now, and then we'll be starting our pathology section. Are you guys enjoying the bootcamp session?
Yes. Yes. Thank you.
Perfect. So we are already
Yes.
done with embryology, we are done with anatomy, we are done with physiology, the hardest part. Now we are at the pathology, the simplest part, and we are going to cover the entire pathology within next, you can say, 2 hours, right? And for the pharmacology, we are going to continue the discussion tomorrow. So let's have 10 minutes of break and see you after 10 minutes.
Hello? I have a question, Dr. Amit, about the assessment.
Hello? Hello?
Yes.
Okay. So, okay, so we'll be starting our pathology now. Just give me a second. Let me first of all share my screen. Okay, perfect. So we'll be starting from cardiac pathology, and the first topics which will be begin from which we'll be beginning our discussion is congenital heart diseases, right? So we already have discussed everything quite a big detail. Dr. Moss did everything quite well. So again, I'll be asking you some questions, and you guys have to be telling me that. Okay. So Dr. Shazail, can you please turn on your mic? Hello. Dr. Rebecca, can you please turn on your mic? Hello.
Hello, I have a question.
Yes, please.
It's about the assessment
Mm-hmm.
because it's going to be like 3 a.m. or 4 a.m. where I am
Mm-hmm. Okay.
when you're going
So
to share
no
the assessment.
worries. Okay, we can. That isn't any issue. We'll just do some topics from the pathology. As like today, we just keep on repeating things a lot. So I don't think so that this bootcamp session can be entirely done today, right? So we'll just for tomorrow. Again, I'll be just sharing your task. So the assessment is going to be day after tomorrow, right? Since like we have a lot of topics left now, so you don't have to
Okay.
be worried. Okay.
Okay, that's
So,
thank you
so
so
So,
let's
much.
doctor, tomorrow will not be starting the endocrinology.
Thank you, thank you, thank
no,
you.
then we cannot start
Okay,
okay, we
thank
can
you.
do one thing. Yes, we can do one thing. Listen. We cannot compromise the schedule as well. So tomorrow we will just start endocrinology tomorrow with Dr. Moaz, and with that I'll be just taking those extra classes to finish off this bootcamp session. I think that's a good idea, right?
Yeah, that's perfect.
Okay, because like we cannot move away from our schedules as well, right?
And
Yes.
In the
doctor,
schedule.
one more idea I have. After the class for
Mhm.
endocrine, this task, don't share it tomorrow, okay? After tomorrow.
Okay, so I'll just I won't share tasks tomorrow. Like today, I'll just share tasks for pharmacology. Just do that. Tomorrow, you guys can give your assessment, and day after tomorrow, I'll just share the task for endocrinology. Okay.
Yeah,
But we
also,
don't have to.
doctor, sorry to interrupt.
Mhm.
Also, we want the recording, the last recording about the pharmacology class. We
Okay,
were
sure.
reading this.
Okay, I'll just provide that recording. You don't have to be worried. Okay, I'll just
Thank you so
upload it.
much.
Okay, you're welcome.
Um,
Like
I
sometimes.
also
Mhm.
wanted to ask if it's possible to get the recording the same day, because if we receive it the next day,
Okay, let me
it
just
some
tell you
of us
the
are
issue.
behind.
Let me just tell you the issue. What's the issue with the recording, right? So first of all, like once all of the participants leave the meeting, then we can get recording. So like normally in the meet, once I just leave the meet, so some of the students stay there, right? So due to that, the recording get delays. Are you guys getting me?
Yeah.
Hello?
Yes.
So
Okay.
you guys should just directly each and everyone should leave the recording the session after we are ended so that we can just get recording. And besides that, like it takes 3 to 4 hours to download that recording since they are like 2 to 2.5 hour big sessions, and it just take a lot of time to get uploaded on YouTube as well, right? So that's why the recording get delayed. Okay, so it's not
Okay,
like
so we'll make sure to ask everyone to if they have any questions, to just send it in the discussion chat so that it's not delayed further.
okay, sure. So like it would be better if you guys can just, each and everyone should just leave the meeting so that we can just get a recording. And besides that, it takes like some time to get uploaded, like to get downloaded from the Google Drive, and then we have to upload it. So that's why it's taking time. So it's not issue on our side. We are just trying our best, but it's like that. Okay. So let's start our discussion. Yes, so you can see like doctor already mentioned, like people stay here after even like 1 or 2 hours after the meeting, so that's a problem. Okay, so you should just leave the meeting as soon as possible after the session. Okay, so let's discuss our first pathology, that is persistent truncus arteriosus. So Dr. Rebecca, can you just please turn on your mic? Okay, anyone else, please? Okay, we are going to discuss a few topics. You don't have to be worried about that. Okay, so please just you guys if can give me like half an hour, so we'll just cover as much as possible, and we'll just continue our session tomorrow after Dr. Mohan's class, right? So please do participate. Kindly just put in your efforts so that we can finish off our boot camp session, and we can just refresh our knowledge as well. Yes, Dr. Abdul. Persistent truncus arteriosus.
Yes, sir. So, sir, basically, the persistent truncus arteriosus is that the arteriosus is not dividing, like it fails to divide to develop the pulmonary trunk and the aorta. And it happens because of the neural crus cell migration. Because when those cells migrate, they go to the endocardial cushions. And then the endocardial cushion, they form that septum, the aortopulmonary septum, which will then form the pulmonary trunk and the aorta. But when that does not happen, so we will have the persistent truncus arteriosus.
Perfect. Okay, for example, if the neural crest cell migrates, they form the septum, but there is problem with spiraling of that septum. What do you think? What would be the condition then?
Then we will have the transposition of great arteries.
Perfect. So we are going to have two parallel circuits in that. What will happen to the mediastinum? What would be the characteristic appearance on chest X-ray? Really important, very high yield.
So basically, we will have on the chest X-ray, there will be a egg on a string kind of appearance, and there will be a kind of a narrow mediastinum. Because spiraling has failed, and we will see that the pulmonary trunk will be arising from the left ventricle, and the aorta will be arising from the right ventricle.
Perfect. Okay. So can you just tell me what's the first line of management for these kind of individuals?
So we have to leave a shunt open, like we either if the shunt present, so we enlarge it, or we leave the shunt open, like the PTA or something like that.
Perfect. Perfect. So the next pathology is TOF. So Dr. Abdul is explaining quite well. So, Doctor, let's give this opportunity to Dr. Abdul. So, yes, Dr. Abdul, can you just tell me what is TOF? How do we get that?
So, sir, basically there will be four defects in this disease. That there will be the pulmonary infundibular stenosis, and there will be the right ventricular hypertrophy. There will be an overriding aorta, and there will be a ventricular sepsis.
Okay, what's among these four? Okay, Dr. Muskan, are you here?
Yes, doctor.
Okay, perfect. Dr. Muskan, can you just tell me what's the most dangerous one in all of these four conditions?
This one, pulmonary infundibular stenosis, because this, how is it called? Right outflow tract obstruction? Yes.
Perfect. Right ventricular outflow tract obstruction. So if we have that, all of the blood is going to enter into the deoxygenated blood is going to enter into the systemic circulation. For that, what the mother is going to tell the individual?
To do squatting. To do squatting.
To do squatting. And how would squatting improve? We know the physiology now.
Because it will increase the systemic vascular resistance, therefore it helps in reversing the
afterload. Perfect. It would increase the resistance. It would increase the afterload. Now the blood is going to enter into your pulmonary circulation. It can get oxygenated, and the attack spells are going to be resolved. Can opening of ductus arteriosus have this condition?
Yes.
Perfect. Again, whenever we have open ductus arteriosus, more blood is going to enter into pulmonary artery. It's going to get oxygenated, and things are going to be well done. Okay.
Yes.
Okay, so we are going to do some selective topics. So ventricular septal defect, you did that. You already know that. Atrial septal defect, we already know that as well. S2 splitting and everything, we know that. Okay. So you guys can just have a read on that. Patent ductus arteriosus, we all know that as well. How does it close? Endomethacin, everything, murmur associated with it. We know everything. For example, if we have right to left shunt for a longer period of time, it will lead to Eisenmenger syndrome. What is Eisenmenger syndrome? Yes, Dr. Muskan.
Yes, doctor. So in this Eisenmenger syndrome, what will happen when this shunt, it will be reversed, right? So there will be a lot of blood will start to go in the pulmonary circulation. So we see pulmonary hypertension, and we have three main signs: polycythemia and clubbing, and one more, late cyanosis.
Perfect. Okay. So the next topic is coarctation of aorta. What is coarctation of aorta?
It is the narrowing of this aorta at the point where we have this, how is it called? Ductus arteriosus, yes. And we see this in the...
If you have narrowing, so my question for you is, what would happen to afterload?
Okay, just a moment. Afterload, narrowing, yes, it should increase.
If afterload increase, would there be any kind of hypertrophy?
Yes, there should be hypertrophy of the
With hypertrophy?
Okay. It means it here should be, yes, concentric, I think so.
And which heart sound is associated with concentric hypertrophy?
S4?
Yes. So can we see S4 in coarctation of aorta? Yes.
Yes.
Perfect. So if we have narrowing of aorta just before that ductus arteriosus, so it means all of the pressure is going to pool, like a lot of pressure in the upper extremity. So would it lead to upper extremity hypertension while the lower extremity is going to be hypertensive? Diminished
Upper
pulses.
extremity hypertension and lower will be hypo.
Perfect. Diminished pulses and
Yeah.
everything, femoral pulses. So now if we have this coarctation, then there is going to be a collateral circulation, all of the blood flowing through some collaterals. What would be they? Yes.
From the posterior to anterior via this intercostal arteries. And we
on the X-rays, on
rib
imaging,
notching.
on the rib notching. The
Rib notching.
intercostal runs in parallel with your ribs. So as they keep on pulsating for chronic period of time, it would erode the bone there, which is going to appear as rib notching. Okay.
Rib notching.
Okay. As we are having a lot of blood within the collateral, there is going to be some murmur. And where are we going to auscultate that murmur? One of your UWorld MCQ. Yes.
I think it is continuous murmur.
Where are we going to auscultate that murmur due to increased flow within the collateral?
Posterior chest wall.
Posterior chest wall.
Between
Between sternum. Between
Interscapular area.
scapula. Between scapula.
Okay, so who said sternum? Sternum isn't posterior. Okay, between scapula. Which other murmur can we hear between the scapula?
Coarctation.
Coarctation is done. What else? PDA.
PDA.
PDA. Just keep these things in mind.
But
PDA
that
can
will
also,
be heard anteriorly.
that would be heard anteriorly. It can also
In the
be heard
PDA murmur will be heard anteriorly in that area, while the
infraclavicular. You can
coarctation will
hear.
be posteriorly.
Okay, so you can hear it in the posterior interscapular space as well, the PDA. Remember that, okay? So normally it's in infraclavicular, you can hear it there, but also, in the back. So you should just keep these two things in mind. S4 heart sound associated with coarctation and, murmur due to collateral blood going there, posterior interscapular. Just keep that in mind, very important. That isn't mentioned in the first aid, you can just write it down, okay? So if you have a lot of pressure in the upper extremities, hypertension, it would lead to aneurysms?
Yes,
Very
very aneurysm. Yes. So
perfect.
yeah.
Perfect. Aortic rupture as well. Endocarditis. Again, we have pooling of blood stresses. Stresses due to infection. Endocarditis. Right?
Yes.
Perfect. Okay. Now let me just give you a scenario. We have an individual. The upper extremity oxygen concentration was high. The lower extremity oxygen concentration was less. I'm not talking about the pressure. You should be okay. So you have only a single differentiating feature in order to differentiate coarctation from PPH.
PDA.
Yes.
PDA
For
right to left.
coarctation, there is going to be high pressure in the upper extremity. In PPH, you are going to have high oxygen concentration in upper extremity as compared to the lower extremities. Why? Why is that so?
Because
There is
PDA is
right
just
to left
simply
shunt in
coarctation.
PDA. Then it will dilute the blood and it will decrease the saturation in the lower limbs.
Perfect. If we have PPH, that is a lot of due to meconium getting into your lungs. We have a lot of resistance there. So the blood is going to move through PDA. PDA attaches. Okay, one of your UWorld MCQ. PDA attaches your pulmonary artery to which part of your aorta? Descending aorta basically supplies your lower extremity. So if you have PPH, blood is going to go directly into descending aorta, and descending aorta now is getting deoxygenated blood. So won't we be having discrepancy in oxygen concentration in upper extremities and lower extremities?
Yes.
Perfect. That's perfect. Keep that in mind, okay?
And one more thing that in PPHTN here the pulses are just normal, while in the COA we have their difference, brachifemoral
Pulses are, yes, so that's obvious that it's going to be due to oxygen saturation difference. Okay, so all of the other things almost normal. So the next topic is going to be hypertension. That's easy. I already discussed this with you. So you should just read it, right? Hyperlipidemia and hypertension. It's like, I would say, the easiest topics you can have, right? Just note down your your homeworks. Okay, so today we are going to discuss till myocardial infarction, and then we'll be continuing our discussion tomorrow because it's very late in a lot of places. But almost we can say we are done with a lot of things, a lot of difficult things, right? So now the discussion for is going to be really easy. So the next topic which we are going to discuss is atherosclerosis. Very simple. I just told you guys what's going to be the first event, endothelial injury, right?
Yes, sir.
Endothelial injury form cells coming there, LDL, your macrophages catching your LDL, creating form cells. It would lead to formation. Okay, so the platelets growth factors and fibroblast growth factor is going to lay a smooth muscle cell wall on that. It's going to strengthen the integrity of your atheroma. For example, if we have increased activity of matrix metalloprotease, what would happen then?
ECM deposition.
There would be
Extracellular matrix deposition.
okay, perfect. Just give me a second. Okay, so if we have rupture of atheroma, it can just get lodged into the further branches, which is going to give us complete occlusion of your arteries. Complete occlusion on ECG is going to give us what? Elevation, depression.
Elevation.
Elevation.
Perfect. Partial occlusion.
It's elevation.
What does elevation indicates?
Infarction.
Transmural infarction, not only infarction. Okay, and if we have like only limited part of the lumen which is occupied by atheroma, then we are going to have ST segment depression, which shows ischemia or infarction of subendocardial region. Just keep that in mind. Okay, so we can have like emboli as well, like it can get embolized into different places, and whenever we have emboli of that, we are going to see like a needle kind of structure, if you guys remember, right? Hello? Cholesterol emboli.
Yes, sir. So
That's a needle kind of structure, right? A hollow
Yeah.
needle kind of structure.
Hollow needle kind of structure.
Yes, perfect. Then we have arteriolosclerosis, two types, hyaline and hyperplastic. We have an individual, he died of hypertension. We just undergo a biopsy of his, let's suppose, arteries, there was an onion skin appearance. What do you think it was?
Hyperplastic.
Hyperplastic. Perfect. Next topics are aortic aneurysm. So we discussed that in detail. I'll be just going through this aneurysm. Okay. I'll be asking you some questions. Dr. Margaret, can you just please turn on your mic?
Doctor, I am at work. Sorry.
No problem. No problem.
I'm
Anyone
here. I'm
else?
listening. That's why I cannot participate. Thank you.
No. Dr. Paul. Dr. Paul, can you please turn on your mic? Hello. Dr. Dr. Savera. Dr. Savera, can you just tell me what is aneurysm? What is aneurysm?
Aneurysm, it refers to the dilation of the aorta, and it can happen like in the thoracic region and the abdominal region, and we have two forms of it. TAA, which is the thoracic aortic aneurysm, and AA, which is the abdominal aortic aneurysm. The difference between them is that the biggest risk factor in TAA is the hypertension, and in AAA is the strongest risk factor is smoking or tobacco. So,
So aneurysm basically is a dilatation, which is due to weakening of the wall. How do we get that weakening? In case of thoracic aortic aneurysm, if we have that dilatation, first of all, you should just think in mind it would lead to some compressive symptoms, right? Dysphagia, it can lead to Ortner syndrome as well. Because we have a big dilatation in the thoracic cavity, it can compress things, right? It's due to weakening of aortic wall. How do aorta get weakened? Hypertension, as we discussed, vasa vasorum becomes more thin. It won't supply the wall. If it isn't, it would become weakened. It can lead to dilatation. Marfan syndrome, no fibrillin, no cement, weaken leads to dilatation. Syphilis, tertiary syphilis, perfect. Okay. So as we get aortic root dilatation, it can lead to aortic regurgitation as well. You already know that thoracic aortic. Now we had an individual, he has a pulsatile mass, anterior abdominal mass. I already told you have a ULM. What's your diagnosis?
Abdominal aortic aneurysm. Hello?
Oh.
We can't hear you, doctor.
Hello?
Hey everyone, Dr. Ahmed said the session is over. He posted in the WhatsApp group and he asked if everybody could leave the session so that the recording could be done.
All right, thank you.
Thank
You're
you.
welcome.
Thank you.
Okay, thank you.
Thank you. Thank you.